Thank you very much, Sam. As usual, excellent job. Thank you for starting us off on time. And welcome to all of our presenters and to all of our participants this morning. We have some great topics lined up and great speakers for you. We are going to have Dr. Donald Gordon open us with some welcome remarks. Our sponsors for this morning's session is Sandus, and we're very grateful for their being a sponsor for our conference this morning. Without them and without companies like them, we really couldn't have these kind of opportunities. Our first speaker will be Dr. Rhonda Hudson, and followed by Dr. Akshay Mansingh. So we have some very good things lined up. I'm going to turn over to Donald to do some welcome remarks.
Hello.
Hey, Dr. Gordon. Hi. We can hear you.
You're hearing me, but I'm not hearing you. Peter, you're supposed to, can you give us a word of prayer, please, before we start?
Sure. Let's pray. Father in heaven, thank you so much for this morning. Thank you for the opportunities that you've given to us. Thank you that we can use this opportunity to learn more about sports, especially as we have our Olympics coming up later on this year, and we have athletes going to different events. Help us to be aware of what needs to be done. Thank you for the speakers and for their experience in this area. And we pray that we will glean a lot of important tidbits. In addition to that, we ask, Lord, that you be with our country. We are going through our spike in COVID, and we see this all over the world. Please be with all of our frontline workers. Please be with all of our professionals. And we pray that you protect and guide them. Please give us a reprieve from the current situation. And please be with all of the specialties as we take care of COVID patients and our regular patients. Help us to do it excellently and safely. We love you. We thank you. We pray in Jesus' name. Amen.
For that wonderful word of prayers, very inspiring. Good morning, presenters, colleagues, participants, sponsors, representatives, and last but not least,
Not hearing you now, Dr. Gordon. No, not hearing you. We can see you, but we can't hear you. It's almost like maybe your microphone was plugged out or something. Can you hear me, Dr. Swebe?
Yes, I can hear you.
Yeah, we're not hearing you, Dr. Gordon, at all at the moment.
I think he's frozen.
Yeah.
Oh, he's back on. Back with you, Donald.
Hello, are you hearing me?
Yep, we're hearing you now.
All right, okay. Let's quickly. Good morning, presenters, colleagues, participants, sponsors, representative, and last but not least, representative of the administration led by Lynn and Oldgate Solution, who have worked tirelessly behind the scene to make participants. We welcome you this morning to our second of 4 quarterly webinar. And the theme of today's webinar is sports medicine. Our aim is to look at sports medicine from a GP perspective and see what issues and clinical conditions we may encounter Special greetings to our presenters. Special welcome to Dr. Kevin Jones, President Dr. Justine Edwards, physical therapist of the Jamaica Association of Sports Medicine. They are with us for the first time. Welcome back to Dr. Akshay Mansingh, Dean of UWI Faculty of Sports, as well as Dr. Rhonda Hudson, President of the Jamaica Emergency Medicine Association. They are no strangers to ATPJ, as they have shared their expertise and knowledge with us in the past. We welcome our sponsors. A special welcome to Sanders, who have generously contributed to sponsor the first session. Sanders has always been a keen supporter of the Association of General Practitioners of Jamaica CME activities. And for that, we thank you very much. Our second session sponsors, we thank Indus, Medimpex, and Abbott. Without their support, CME activities would be difficult for us. They are always very consistent in their support, and for this, we thank them very much. My fellow audience, in concluding my remarks, I extol you to be very careful, as during the past 2 weeks, the graduating class of 1980 has lost 2 members to COVID-19. So please take your vaccines and encourage your staff, your family, your friends, and your families to do likewise and be very careful. So please enjoy the webinar, and remember, please participate in the poll tests and the pre-tests, as it is necessary in order for you to get in your CME activities. It's not about how many you get right or how many you get wrong. It's really about engagement and participation. And please relax and enjoy the sessions, because it's a wonderful session, very knowledgeable panelists. And I hand you back over to Dr. Swaby. Dr. Swaby.
Thank you very much, Donald. And our first presenter this morning is going to be Rhonda Hudson. She's a native of Georgetown, Guyana. I did not know that, Rhonda. And past student of the Holy Childhood High School. She received her MBBS from the University of the West Indies, and later a Master's of Science and a doctorate degree in Emergency Medicine, 2002. And in 2009, she received a Master of Science in Sports Medicine. She's currently a consultant emergency physician at the University of the West Indies and associate lecturer at the University of the West Indies in Jamaica. She is team physician to Jamaican athletes for local and international games. She's done the Central American Games in Puerto Rico in 2010, Mayagüez 2015, Pan American Games in 2011, Toronto in 2017, Lima in 2019, and the Commonwealth Games in Glasgow in 2014. So she is very able to speak on the topic screening, evaluation, and management of the injured athlete requiring emergency treatment. Rhonda, welcome, and thank you for your presentation.
Thank you very much, Dr. Swaby, and I extend my thanks as well to the Association of General Practitioners through Dr. Donald Gordon for this invitation to be back with you. So we're going to talk a little bit about that, and we're not going to get into every single nuance there is, but hopefully what I would like to do is present to you a sort of overview of what any doctor may encounter and how to treat in general terms, and essentially what to do with athletes. So let's begin with some definitions as it is. Now, there seems to be a sort of debate as to how sports injuries are defined. And this is the CDC's definition as it relates to high school athletes. So there certainly must be some organized activity, and the injury must occur in such a way that the athlete seeks medical attention from a trainer or a physician, that it interrupts participation for 1 or more days beyond the injury, and whether or not there's any possibility of an athletic injury resulting from the play defines a sport injury. And a more perhaps scientific definition would include the one you see here. Essentially, anything that interrupts competition or practice, leading the athlete to seek medical attention. Now, if you do a sort of Google search on common types of injuries, this is a list you'll get in particular in this order. And for the most part, the studies support this. So this is a particular study that I found here. And what is important to notice is that not just the game, and it's intuitive, yes, But it's not just the competition is associated with injury, but also practice. And the commonest type of injury seems to be sprains and strains. And depending on the study, the frequencies vary. But essentially, those listed here are the ones that people, athletes tend to get involved in. A study that looked at the types of injuries by sport, and we noticed that, and this is American football, accounts for the majority of sporting injuries in this particular survey, followed by basketball, a little bit by track. But look, this green here represents free time play. Okay, so I'm sorry, something just came up on my screen. Okay, I had to. All right. So essentially, free time is associated with injury, and we need to be to bear this in mind. So when we speak about sports and so on, it's not just about competition and intense training, but just participating in sports may increase your risk of injury. Mm. And again, when you look at the injury in young, what we might call young adults, and persons may decide whether age 40 is young, I think it is. And what this really shows is that the majority of them occur in males. Males tend to have more injuries in general than females, although this will vary from sport to sport. And there are other studies that show that females have an increased risk of injury than males, depending on the particular study. And when we look at the types of injuries when related to the type of sports, the injuries will vary. So for example, if you look at bicycling here, we know that head injury and shoulder injuries are what are seen more frequently in this particular survey. And if you go to basketball, the ankle is the place injured the most. And then if you look at baseball and soccer, they tend to share their injuries here. So the idea is that it's not a kind of one size fits all. It is very sport specific in terms of, one, are you injured? And two, what type of injuries you're more likely to get involved in. And perhaps that is intuitive. If we look at the injuries by body part, essentially all of this here represent the lower part, right? So lower limb injuries tend to predominate if you compare them to upper limb injuries. This one is particularly important, cervical spine injuries, and we need to be very, very cognizant of that. And while we get distracted by things that are gross and so it's sort of in your face, that cervical spine injuries may not be very dramatic in its presentation, but can have deleterious effects, and we need to be mindful of that. A look closer to home, this was a study done by our own Dr. Man Singh and Dr. Singh, and essentially looked at netballers. And what they found is that, similar to what we were seeing elsewhere, that injuries on a whole are confined to the ankle and the knee. And some risk factors for that was some leading to the playing surface itself, and there were some athlete-specific reasons, like how they landed and so on. Another Jamaican study looked specifically at hamstring injuries, and it essentially what it found that hamstring injuries are very common in the age group 7 to 21 years of the sport studied, and that track and field accounted for the majority of hamstring injuries, with football, hockey, and cricket coming in a kind of distant second. There are numerous risk factors for injuries, and it varies from what persons call intrinsic factors, and that is intrinsic to the athlete, him or herself. Sex, predominantly, as I said, depending on the study, a lot of it is showing that females actually do sort of injure themselves more than males. And of course, the older you are, you're more likely to be injured during sports. And things like body composition, so weight and BMIs and so on, your fitness level, of course, will affect how or why, if you get an injury, your previous health, your current health, your previous health, and then there's things that, anatomical factors that may increase your risk of getting an injury. Do not take away the skill level. We know, and it has been shown that the skill of the athlete may be protective, or high skill. The more skilled you are, the more trained you are. That makes sense. Then that may decrease your risk of injury. And more we're seeing that a risk factor for sport injuries are psychological parts of that athlete. So depression and mood disorders and so on will increase your risk. And then there are things that have nothing to do with the athlete per se, but have to do with other things. So a big one is the team, playing team sports, right? So you have to look at your athlete, your other teammates may increase your risk of getting injury if they themselves also have risk factors, or just the whole team dynamics during the sport. And then there are other factors like coaching and rules and all these other things that may affect whether or not an athlete is prone to an injury. We understand protective equipment. They may decrease injuries. We know that sporting equipment as well can increase injuries. So if you think of and the game, for example, hockey, with that hockey stick. If you ever watch a hockey game, it's a very dangerous game. Just the act of playing it increases your risk of having sport. And then there are other things like environmental factors. And we saw a little bit of that in our own study with the netballers, that the playing surface is a big factor in increasing the risk of sports. And what was shown in a study was that non-organized sports have a greater likelihood of risk of injury than sports that are organized. And some of it you may be able to say, well, that makes sense, because you're more likely in organized sports to have perhaps better surfaces, better training programs. It's more a little bit more rigid and organized in how the training and the game goes. What is known is that the one risk factor that seems coming up in just about all studies I've looked at is that a prior injury predisposes an athlete to re-injury. And it doesn't really matter if that injury occurred 2 days ago or 2 years ago. Just the history of having that injury increases the risk. And the other one that was particularly interesting is that if the athlete is concerned or preoccupied with the notion of getting injured, that increases that athlete's risk of being injured. If we look at some team dynamics, this particular study show that one, team sports are associated with a higher risk of injuries than individual sports, and that may make sense. But what they also found that the team sports, they tended to have more competitions compared to individual sports. And that was associated with a higher risk of injury. And if you compare to individual sports, they have more intense training sessions, and that was actually more protective. So when you're looking at injury risk of an individual, there's so many things to take into consideration. And whether it's a team versus an individual, that's important in assessing risk. This was a study, and it's a recent study, and I highlight this study because it shows something that I think we need to be aware of. It's nothing essentially new, but it essentially says that the risk of injury is associated with sports specialization and intense training patterns in young athletes. What it found, that apart from the fact that in this study, again, that females, and the younger you are, that was more so, that they have a higher risk with a high degree of specialization. that if training hours exceeded your stated age, so if your training hours per week exceeded your stated age, that increased the risk of injury. And if your training hours exceeded your playtime, that also increased the risk of injury. And that is very important, I think, for us to bear in mind when we look at young persons participating in sports. And one of the things it was shown a long time ago that high degree of specialization is really a factor in injuries in children. And perhaps we should reconsider how we encourage young children to get into highly specialized sports, but that's for another time. We know, for example, that injuries in sports have a lot of effects, and this perhaps one might consider the least problematic, of course, from my perspective. To an athlete who has to withdraw from a game, then that could be devastating in a lot of ways. So we know that you have that, and then you have the long-term injuries. So there's morbidity, there could be mortality, etc. So what do we then do about it? Is something we can do? Can we predict it? Can we do something before it happens? Now, when I was doing my master's in sports, I was introduced to the whole concept of screening, and we used to say PPE, pre-participation evaluation. Now, PPE these days have nothing to do with sports and everything to do with COVID. But before then, that's what it meant, a pre-participation evaluation. And the notion was that you try to detect risk factors for injuries. And the notion then too is, could you do something to prevent? Could you intervene to prevent the injury? And in general, a pre-participation evaluation consists essentially of three major categories. You have the cardiovascular, the musculoskeletal, and the general medical. Now, the musculoskeletal part, and we're going to stick to that because we're just keeping to injuries. This has received a lot of studies, and there's a lot of debate in the literature about its value and so on, and screening. So we do know that these are some of the studies that have looked at screening and what does that have to do with injury. So depending on the studies, essentially a positive test, and there are a number of musculoskeletal tests that people get into that are general and sport specific. So we're not going to go into that, but essentially that it has been shown that a positive test, i.e. a particular score or detecting a risk factor, is associated with injury either during competition or during training. A recent study actually looked at this, and they looked at a particular score and essentially said that, look, the test scores were not really different between those who were injured and not injured. And the notion is that identifying a risk of injury with your PPE is not synonymous with injury. And yes, that is intuitive, but the question is then, what do we even do if we identify a risk when we're doing our screening? So is it to prevent participation? And there was, if you look at the earliest studies, especially if you look at cardiovascular risk and screening, even if you identify something particularly bad, then you may prevent the athlete from actually participating in sports, or you may redirect perhaps the athlete to a less riskier sport to help to decrease the risk if you could not modify that risk factor. And then there's a lot of talk of whether or not there's a role for prevention programs to mitigate risk. Generally, there are studies that show that yes, if you do a prevention program, either general or sport specific, you can reduce the injury rates in some sports. The other question, though, is should prevention programs target the at-risk athlete only? And that is where there's this sort of debate. And this was a recent work, a review that has gained a lot of footing and clout in the literature, essentially saying that, look, your pre-participation evaluation, right, should not be used to predict injury. In fact, it is saying it probably can't do that for a number of reasons. It's a very good read. But essentially what they're saying is that in order to really look at sort of like a cause and effect, you have to show that any intervention program that you do is actually associated with decreasing in injury in this compared to doing that injury prevention program to all of the athletes. So, and they said nothing has supported that. In other words, yes, I've identified an injury in an athlete. Does that make, is there any benefit to taking that particular athlete and training that athlete specifically? And there's nothing to say that doing the general prevention to all his team members would be more beneficial. And that is essentially what it is. So what we're saying and what is being touted is to look at the pre-participation evaluation as having the following purposes. To screen for conditions that may be life-threatening or disabling, yes, and you may be able to intervene. It is to screen for conditions that may predispose. But especially for the last three here, this is really being touted as a reason for screening. So yes, we may not be able to predict, and we know that risk doesn't equal injury necessarily, but it gives us a good starting point to engage the athlete in getting a health examination, and it provides an opportunity for discussion on other topics. So what is really the buzzword is not PPE or all the other things you see here, but what is a periodic health examination. And the idea is that what you're really interested in is the health of the whole individual. And I'm not really doing it to determine whether or not you should play sports. We know definitely that it should never be used to determine whether or not an athlete actually participates in sports. So let us look at the evaluation and management of the injured athlete. And I say you begin by watching the game. That's where you begin. It's very important as a physician or the trainer or anyone who is going to be providing the medical coverage that you, if as much as possible, watch the game because it has some benefits. You can witness the mechanism of the trauma. You can evaluate the immediate response of the athlete, okay? Did they lose consciousness or do they look a little wobbly, etc.? Evaluate for any deterioration. Perhaps they got up okay, but you can actually see deterioration even before there's a catastrophic event like they fell or they just stopped playing entirely or so on. So you can actually look at, and then one of the other things you can decide, depending on what you see, whether or not you need to intervene. And there are a lot of sports that have rules with respect to how the doctor intervenes, but you can actually say, no, I want that athlete to stop because I see something that concerns me. So watching the game really is the best place to start evaluating your athlete. Some guiding principles, and not because I'm an emergency physician, but yes, recognize emergencies. Those things that tell you that you need to transfer the patient straight to the emergency department. And we know the ABCD approach: airway, breathing, circulation, and disabilities. The things that are gross, the things that are life-threatening. So airway thing, an unconscious patient, for example, somebody's not breathing well, persons with evidence of cervical injury and so on. And then you want to safely manage the non-emergent injuries. And I put the last part here because this may not necessarily be the major aspect, and I'm not going to focus on that too much, but there may be, because somebody's going to ask you, can the athlete return to play? Some of the things to guide you is there a risk of further injury? We know that having an injury predisposes to another injury. And is there a risk to other athletes with having an injured athlete continue in play? And there, a lot of times, this is very, very case specific, very sport specific. So let us look at a few injuries or injury types, and we'll start with concussion. So a concussion is a syndrome of neurological and pathological dysfunction induced by biomechanical force. So that's a very scientific definition. But it's a clinical syndrome characterized by immediate and transient alteration of brain function, including alteration of mental status or level of consciousness that results from mechanical force or trauma. And yes, different persons will define it a little differently. But essentially, you recognize it by its clinical features. There is a concept of a subconcussion, to muddy the waters a little bit. And this is where you may have a concussion that is said to be asymptomatic. And I say whether or not it was perhaps missed. All right, so there is that category that you also need to be concerned about. There are lots of risk factors. We know that insomnia and daytime sleepiness, psychological things, if you're mean and aggressive, and definitely if you're psychotic, that will increase the incidence. If you're particularly irritable or depressed, will increase your symptoms. We know young athletes are at a risk of developing post-concussion syndrome at a decreased risk, and that is dependent on, again, pre-existing psychiatric illnesses, either in the athlete or in the family, or if they have some sort of psychological stressor, and we know there are other substance abuse or use that may affect concussion risk. And a meta-analysis essentially showed that rugby, high concussion rate, lowest concussion rate in this particular study was in men's football, concussion greater in match versus training. And that, of course, is dependent on the study. And in football and ice hockey, females were greater than males. Interestingly, the studies show that mouth guards were protective. What are some of the symptoms? There are many, but pay attention to memory loss. And this one, loss of smell or taste. And we know in these times, a loss of smell and taste, we think COVID. But long before we were thinking COVID, when we lost our smell and taste, it was a symptom to suggest that perhaps a patient has a concussion following head trauma. So what do you do? So at the game, I would say pay attention to step 1 of the SCAT-5, and then pay attention to steps 2 and 3 after, steps 2 to 4 after that. So what is the SCAT-5? So this is the newest kid on the block. It's your sport concussion assessment tool for sideline and further treatment. And this is the part I'm going to ask you to look at. So essentially, you have SCAT-5. There is no SCAT-4. So that was one of your pre-tests. And you have SCAT-5 for adults and children. And there's some particular differences. So in this adult, they have a part that speaks to alcohol use. And of course, the assumption is that children would not be drinking alcohol. And this is for the child SCAT is used for persons 5 to 12 years old. And this adult SCAT is for 13 years old and above. And what is important to look at in both the adult and the child is that the diagnosis of concussion is a clinical judgment and not to rely specifically on the, whether you score yes or no or so on. You may very well have a score, right? That is normal, but a patient can have a concussion. So it looks kind of like this. In the adult, you have 4 steps, and you ask the questions, you take yes or no, and then you make a determination. This is the one that you will not see in the child. It's the memory assessment questions that you will ask, and it will help you. So this is a red flag. This is the ones that would be your ABC kind of things. Any person with such red flags, you don't watch them. They must go to an emergency department for further evaluation. The key points: any athlete with suspected concussion should be removed from play, and they should not remain in play for the balance of that day. Yes, so it's very important that you understand that. And the SCAT5 is used for medical professionals. The concussion recognition tool is the simplest one used for persons who are not medical professionals. When we look at extremity injuries, essentially want to prevent injury, minimize the zone of injury, decrease pain. And just remember that when you've decreased the pain of the athlete, it doesn't mean that the injury has gone away. It promotes healing. And what you want to do is to allow safe return to competition. And I have put here function. Ligament injuries go from grade 1, it's mild. Essentially, they can return to play once they are pretty much pain-free and you have no instability. Grade 2 ligament injuries usually have some amount of functional problems, for example, inability to walk on the limb. You're going to remove them from play, and most persons will say that these patients should actually consider getting an X-ray. So a person with this kind of injury should not go back to play. Definitely grade 3 ligamentous injury is really a worsened kind of injury. They cannot bear weight on the limb, and you may detect instability. You're going to remove them from play, and you're certainly going to send them on. So here, inspection alone won't work. You may have difficulty in assessing for stability in a patient who has a lot of pain or a lot of swelling. And therefore, in these patients, certainly with grade 2 and 3, you always have to consider if there's a fracture, and you may have to, you should send these patients on for radiological assessment. They probably should not go back to sports unless you can rule out those things, and they will require treatment. And lots of rules as to when they should return to play. But in the immediate setting, certainly a grade 2 or 3 ligament sprain should go on. Dislocations are dramatic, as is the mechanism of injury, and you have ankle, you have patella dislocations, shoulder dislocations recognized here by the so-called squaring of the shoulder, loss of the deltoid conform. You can see a little flattening here, as composed to this side. The patient is going to be unable to abduct and have difficulty flexing. Elbow dislocations, here you have to worry a little bit of arterial injury, but here again, this is an obvious deformed limb here. And then you have knee. And knee injuries knee dislocations, very, very important. Most of the dislocations, one of the things, apart from the actual pain and deformity and so on, you have to consider the possibility of neurovascular injury. Clearly, you must remove them from play. You want to reduce it promptly. Now, for the most part, reducing dislocations are going to require analgesia and sedation. And we always say we consider a fracture. Now, these are traumatic injuries. So though if you were to read the literature, people talk about reducing it promptly. If you can, traumatic ones, rule out a fracture first, because that may affect your ability, 1, to reduce it, and 2, you may have further injury if you try to do anything with it. Consider a vascular injury, and I would say transfer all patients to the emergency department. And this was a case, a medical legal case that was won by the plaintiff. And I like this particular advice that whether pulses are present or not, a knee dislocation, and perhaps any dislocation, is an orthopedic and vascular emergency and treat as such. Who stays and who goes? Anything life-threatening, anything limb-threatening. And a lot of it depends on the medical personnel available and your skill level, right? If there's no threat to limb or life, but need removal, you can stabilize the patient and refer to a later time. But any significant functional limitation, suspect a more serious injury, and then you can make a case-by-case decision on milder cases. Transfer bottom line, Anyone you suspect of having a vascular injury, long bone fractures, open joint injuries, and major joint dislocations should be transferred. Something that we don't think about a lot, but can occur, and essentially it's not rated as the commonest of injuries, but dental injuries from sports is the commonest type of dental injury, all right? And as you see here, and a delay in treatment is the single most influential factor affecting prognosis. So there are lots of things that can go wrong. How you manage, I say, after airway and breathing. And in airway, especially when you have loose things, be mindful of airway. Loose teeth can present an airway problem. Call for a dentist. That is what I see with dental injuries. Find out if there's one in the audience and ask. Essentially, you really want to get these patients to a dentist as quickly as possible. So you may have crown fractures, as you see here. Recommended could use some things like calcium hydroxide to assist, but essentially get them to a dentist. If you have pulp exposed, as you have here, this is when your calcium hydroxide itself is said to be useful to prevent the pain. Dental intrusion here is when it goes up, and the extrusion is when it goes down. If you have this injury, do nothing, get the recommendation, get this patient to the dentist as quickly as possible. If you have such an injury, the extrusion, gently push it back up and then splint it and get the patient to the dentist. If you have dental avulsions, these are the ones where the tooth is knocked out. Try to reimplant it, do it quickly within 5 to 10 seconds. Do not be aggressive with washing, but wash out, gentle washing if there's any dirt. Try to put it back in and splint. If you cannot reimplant it, you can store the tooth. And there it's in the order in which it is recommended that you do it in a special media, but you could use milk, saliva, saline, or water if all else fails, if you don't have any of those things. And you could take the patient quickly to the dentist. And these are things that are ready-made. We don't have these in Jamaica, but these are considered to be important. Certainly, maybe a good thing to have in your bag. Splinting. If you read sports injury journals and so on, they'll tell you about all these various things. A dentist will say to you, the dentist that I consulted, say, look, if you have injuries, avulsion injuries, just pretty much, just have them hold it in. They can bite down, don't bite too hard, but really just get them to the hospital as soon as possible, okay? And this was essentially this particular quote: with all possible haste, get the person, especially if you can't, put it back in. For TMJ dislocation, if it is traumatic, then I would say send to the ED so we can rule out a fracture before you attempt to reduce it. And there are lots of, if it's something that just happens and it's recurrent, then you could attempt to put it back in. Eye injuries, this is a study that pretty much showed that basketball accounts for the majority of eye injuries in the United States, and it can be prevented if you use protective glasses. And eye-safe sports are exercise, jogging, running, walking, and so on. And you see the risk there according to the other games. So we know hockey and some other things, as you see, they're very high risk. Abrasions are possible. And essentially, if you see it, put some fluorescein dye, topical antibiotics, no eye patch. And these patients can be seen by an ophthalmologist urgently, but not emergently. Hyphema can be as dramatic as the one on the left or very small as the one on the right. These patients should be referred to the emergency department. Certainly, if you have an orbital blood fracture, you will notice, apart from the gross things, what you see here, there'll be paresis of upward gaze, and these patients should come to the emergency department. Do not stand around trying to do anything. They definitely should not be returned to play. They're going to have vision problems. Globe rupture, again, can look a lot like a foreign body, but you recognize it by the fact that the lens here is very irregular, and you can have associated ecchymosis here. And these patients should be referred immediately to the hospital emergency department. You want to place an eye shield, not an eye patch. There should be no pressure on the eye. Do not wash it out, no drops, nothing. Get the patient straight to the emergency department and consult with an ophthalmologist immediately. Then there's certain miscellaneous things that we could do that may help us. For example, we might do this on our own, i.e. suture something like this. But if you have this injury, any injury involving the lid margin should be referred. Do not attempt to do this on your own, no matter how skilled you are, except you're an ophthalmologist. So if you look at the evaluation of the acutely injured athlete, you want to detect life threats, detect limb threats. Those should go straight to the emergency department. You want to determine the need for immediate transfer to a medical facility by looking at your ABCs. And if you are called to, and if there's any pressure, you want to still have a rough, fair idea of who it is you should return to play either the same day or the same play. And that is going to be very case specific and athlete specific. And if you do a very good job, then you're going to have a very successful athlete, a very happy athlete. Ladies and gentlemen, thank you so much for your time and attention.
Thank you so much, Lorna. That was a wonderful, very succinct and clear presentation. We are going to open it up for question and answer, after which we're going into our sponsor's presentation for the morning session. Can you field those questions for me, please, Sam?
No problem. Thank you very much. Hey, guys. So anyone with any questions, please go ahead and let me know in the Q&A. Checking so far, not seeing any questions, but getting a lot of kudos in the chat for Dr. Hudson and her presentation. Dr. Gordon would like to ask a question. Let me let him go ahead. Dr. Gordon, question from you.
Hi, Ron, a very excellent presentation. Almost the last slide, I saw an injury of the eyelid and something like a Q-tip. But in boxing, I see they do that very often. They put stuff inside there and seal it. What do you say about that? And also, could you mention something about injury to the nasal bones as well?
Okay, can you hear me now?
Yes.
Yep.
Okay. Now, one of the respect to how injuries are handled, as I said, they're very sport specific, and there are rules that will govern what you can and cannot do, and so on. Now, from a purely, I would say, let me say from a medical perspective, that when you have eyelid injuries, and I'm talking about where the lid margin is affected, whether you remove a person from play is going to be, again, is what the sport will allow, or whether or not you, the doctor, you can make a determination as to whether or not this patient is at risk for any injury. So just the lid margin in and of itself may not be a problem to continuing the sport. You have to examine the eye for other associated injuries like hyphemas and so on, and make sure there's no globe rupture. And then you can make a determination whether or not the injury interferes with participating in sports, increasing the risk of further injury, but also look at the rules regarding, whether you must have blood coming down or not. So boxing is very specific. They have a lot of rules, but in terms of preventing morbidity, the point is, don't attempt to try to say, okay, let me take you to the back into the examination room and try to stitch it up myself. That is not something you want to do. It can have serious problems later on and should best be handled definitively by an ophthalmologist. And the other one you spoke about, what did you say?
Fracture to the nasal bones.
Well, again, that is perhaps more likely to occur with boxing. the thing to look at it is what effect that will have on the sport. And Dr. Mansing is here. And I remember that he told me long ago, and I may not get all the specifics right, but there was a cricketer who there was an injury. I think he had a mandibular fracture, and he can correct me. And actually, he simply splintered him and allowed the cricketer to go back to the sport because it was deemed, one, that he may have been vital. I think it was the last over. And that injury did not interfere with the sport, and probably would not have increased his risk of getting another injury. And he made him go back. And then you could deal with it after the game is over. So a nasal bone fracture in and of itself may not be something you say you must come out of the sport. You have to make a case by case. And the thing you want to be careful with facial injuries in general is that they increase the risk of a concussion. So you have to be careful with that and watch the athlete very carefully.
Excellent. Thank you so much. There is a question in the Q&A. It's from Dr. Chong, Ricardo Chong. What is the difference in police, POLICE, versus price, PRICE, in acute management of injuries?
Okay. Police is a sort of new kind of thing. And the idea, we used to learn RICE, which is rest and ice and compression and elevation. And people came into the price, meaning to protect the injured limb. And then the police part is essentially determining that it used to be that you would keep the athlete rested for a while. And the whole police thing is that try to get the athlete back to walking and movement, I should say, of the injured part sooner than was previously recommended. So it's no longer, if I have a ligamental injury, even if I have a grade 3, you read some of the studies and they'll say, look, try to get the athlete to move the limb as quickly as possible, because that has been shown to decrease long-term morbidity. So, and decrease the time to get the athlete back into into competition and participation. So that was the slight difference. It's just a matter of getting it's how we don't put too much emphasis on the rest part.
Thanks so much. And Dr. Anna Brown Morgan is asking, doesn't pain interfere with the athlete's ability to perform every time?
Well, that is athlete specific, of course, because you may have a very high threshold and you may suffer your pain. And I remember, I always think athletes will suffer through a lot of pain just for the sake of competing. And that's the other part that you may have to understand as well. So yes, the pain may limit them, but they may still want to continue. So that is going to be, you are going to have to make that assessment along with the athlete and along with everyone else. So the important thing is to get the athlete to understand risk. And for us, that, just giving them a shot is not enough to say, okay, your pain is gone, therefore go back and play. You must evaluate the injury thoroughly. You must check for any worrisome signs or things that may threaten the limb later on or affect the athlete. And remember, pain, you can reduce pain and send the athlete back out, but that may not necessarily be in the best interest of the athlete, depending on the particular sport.
Thank you so much. Dr. Martin Taylor. Athletes at the same level of fitness should train together. Is it that athletes at different levels of fitness might create injuries in one or the other athlete?
Okay. I'm not aware of a study that looks specifically at that, but we do know, yes, that fitness level may affect injury in general. And yes, and we know that in team sports, that your fitness level, if you're not so fit, you may very well affect the propensity of injuries for others. But the idea, and that is where the whole injury risk assessment is getting a sort of relook. you should have programs that seek to have all athletes at the same sort of level rather than take one athlete out. If you have, especially if you have a team sport, that any program you put to increase fitness of any athlete should not be designed solely to the one who in pre-testing was said to be at a lower fitness. Yes, you bring them up, but it should not be solely at the expense of the others. And whatever program you do to increase one athlete's fitness level should be beneficial to all the athletes. And therefore, that's where you want to keep them or bring them up at the same level.
Okay, excellent. And Dr. Dion Harrison, is there any ethical concerns in allowing the athlete to continue, even if you know the person's injury is serious and the athlete wants to continue?
Oh, yeah. Okay, ethical issues. There are always going to be some problems. Now, that is going to require more than just perhaps you and the athlete. It's likely to involve the coach, your manager, and the sports officials, because we do have, we live in an era of litigation, and an athlete may want to do something because they're guided by I want to continue playing, or they're guided by the fact that this is money and so on. But what happens afterwards may be a problem. And somebody might say, well, why didn't the doctor do X? So why didn't you stop the play? Why didn't you do so? So at the end, there's some sports that will make it, we'll say, look, the doctor has the final say. And in others, the doctor may not have the final say. And that's a big debate. What I would say, involve the athlete, explain to the athlete, look at and involve others in this decision-making process. And at the end of the day, if you do not have, by rules, the authority to prevent the athlete from playing, then you will have to make sure that you've documented everything very clearly, that this is not your recommendation. That would be my advice.
Fair enough. While we wait for other questions, guys, you should see a question popping up on your screen. Now, this is directly from Dr. Hudson's presentation, and she's smiling. So we're looking to see how many of you get this one correct. So go ahead for me, put in your vote, and we'll leave it up for another 30 seconds. In the meantime, if you have any other questions, please put it in the Q&A. And of course, remember, if you thought the presentation was as good as I did, and so excellent, detailed, vivid presentation with images, please put your ones in the chat as we wait as well. All right. And here are the answers. There you go.
Yes.
All right. Dr. Hudson is very proud. I can see that. And let's ask one more question. Dr. Uwe, or Awi, Osazi Awi, is asking if it's possible to get your slide.
If it's possible to get the slide, is that what you said?
Yes.
Yes, I could send it to Dr. Gordon and he can disseminate.
Sure. So we'll just send it to AGPJ and they'll disseminate it out. And now we're going one more question. Which of the following is the best predictor of a sports-related injury? This is a trick question. That's why Dr. Hudson is smiling so hard.
It's not a trick. I don't do that.
And so we'll leave it up for another 10 seconds. And so we have 1 more minute for Q&A, and then we head over back to you, Dr. Swebe, and have Sanders do their first presentation. So here we go. Here are the results. Not many were tricked.
Right.
Awesome sauce. And the final question from Dr. Clifton Reed. Please speak to the use of ECG in evaluation of student athletes.
Okay. All right, so I'd stayed away from that because we're looking particularly at injuries. Now, the cardiovascular evaluation really should include, apart from a physical examination and a history, an ECG. And that is the general sort of recommendation. The problem is that there's a lot of debate as to whether it's cost effective, should everyone do it, et cetera, et cetera. And if you are a purist, and certainly when I learned about this, it would have been exam plus ECG. And the ECG is to identify a risk of an arrhythmia. For example, does the athlete have Wolff-Parkinson-White syndrome or weird and wonderful things like Brugada syndrome? Do they have a long QT that is congenital that no one would have known? And these things increase the risk of sudden death in an athlete when they go to play sports. So a purist will say yes, but there's a lot of debate that is country specific that would say, well, maybe we shouldn't be doing it for everyone, only do it for persons in whom the history and your examination identify a problem. Maybe because I love ECGs, I would say I will do it in everybody. And certainly when persons come and they ask me, I will ask that they do an ECG, because an examination, a cardiovascular examination, may not pick up an abnormality that may very well lead to sudden death in a patient or an athlete. So I would say yes, but it depends on your pocket too.
All right, thank you. So we're going to hand over now to Dr. Swaby. I see a question from Dr. Hossein White. I'll ask you, Dr. Hudson, if you click on Q&A,
yes,
you'll be able to type an answer to that question, and so
okay,
they'll still be able to get their answer.
Okay.
Dr.
Thank
Swaby, over to you.
Thank you very much, Rhonda. Thank you, Sam. Thanks for filling the question and answer section. Rhonda, excellent presentation. I'm in agreement with you. I love ECGs. I'll recommend ECGs too for my athletes, especially with their concerned parents. At this time, we are going to hear from Sanders. There are session sponsors, and then we're going to move into our presentation from Dr. Mansingh as soon as that is completed. Over to you, Sanders.
All right. So I'm gonna stop you guys' screen for a second. What I'm gonna ask you to do, Sashane, if you could unmute first. Using an iPad, it might not give you the opportunity to unmute once you start sharing your screen. So let's get you to unmute first. Perfect.
All right. Are you hearing me, Sam?
Perfect. Yeah. So go ahead and share your screen now.
Okay.
Like the pull-up banner. Nice touch.
All right. Are you guys seeing my screen?
Yes. So just go to your home screen and then go to your presentation now. Mm-hmm. Mm-hmm. Stop sharing a while ago. Not sure why. Go back into, yeah, it did. Go back into Zoom for me. Right. I'm seeing your screen.
Mm-hmm.
And then let's open your presentation now. All right, generating access to more patients. Go ahead.
Excellent. All right, thank you. Mr. President and all executive members of the AGPJ, Mr. Moderator, all attendees and support personnel, good morning. My name is Sashane Francis, medical representative for Sandoz Pain and Bone Line. And for those who may not know, Sandoz is a subsidiary of Novartis, which is based in Switzerland. And how Sandoz came about was that Novartis Pharma decided to have quality prescription medication become more accessible by providing a more cost-effective solution to patients. Sandoz has a very wide and vast portfolio. However, the focus for this session is on the pain line, which is quite fitting for this forum for sports medicine. So first up, I'd like to highlight our VitaCox, which is our newest COX-2 inhibitor, which has been launched to the Jamaican market in July of 2019. And it has surely made an impact at both the point of sale and for stocking doctors. VitaCox is indicated for both chronic and acute pain. And as you know, COX-2 inhibitors provide improved advantages over traditional NSAIDs, as there is a reduced risk of gastrointestinal effects. VitaCox is available in the convenient doses of 120 and 90 milligrams and is available in pharmacies island-wide. Next up, we have Sandoz celecoxib, a more mature molecule compared to etoricoxib, but still very relevant and available. This is in a 200 milligram presentation and is prescribed either once or twice a day, depending on pain severity. So just to say, like the Innovator brand, our capsules are hermetically sealed to ensure the maintenance of quality and efficacy. Sandoz pregabalin, which now has a brand new name, Kinectia, indicated, as you know, for post-therapeutic neuralgia, diabetic nerve pain, and fibromyalgia. The dosage is 150 to 300 milligrams daily in divided doses. And recently we received a quite attractive price reduction in order for all patients to be able to afford Kinectia, which is our Sandoz pregabalin. Thirdly, or Sertalud, 4 milligrams, which is our centrally acting muscle relaxant. And since our focus is on sports medicine today, Sertalud's indication for painful muscle spasms after high intensity physical activities is one to remember. Sertalud does provide a sedative effect, which normally is considered an advantage for patients experiencing stiffness. However, the tablets are scored and a 2 milligram twice daily regimen reduces that adverse effect to a minimum. Last but not least, Aclasta, which is our once yearly IV infused bisphosphonate, indicated in the prevention and treatment of osteoporosis as well as Paget's disease. And I must say that GPs have become more empowered in administering Aclasta due to the fact that it's convenient as well as it ensures patients' compliance when compared to oral bisphosphonates. So to summarize, our pain line consists of VitaCox, which is our etoricoxib in 90 and 120 milligrams, celecoxib in 200 milligrams, Sandoz pregabalin or Kinectia in 75 and 150 milligrams, or Sertalud in 4 milligrams score tablets, and the Aclasta IV infusion. These and the entire Sandoz portfolio are both distributed by Lasco Pharmaceuticals and CareMed. Thank you.
Thank you very much, Sachin. Appreciate the presentation and sticking to time. We are about to go into our presentation from Dr. Mansingh on the management of the frequently occurring injuries in the athlete presenting in private practice. Dr. Mansingh really needs no introduction. He's a consultant orthopedic surgeon and sports medicine physician who has looked after elite athletes throughout the region. A graduate of the UWI, Dr. Mansingh earned his MBBS and his DM in orthopedics at UWI and a master's in sports medicine from the University of New South Wales in Australia. He's the inaugural Dean of the Faculty of Sports, member of the Medical Advisory Committee for the ICC and the Cricket West Indies, and he's an independent board member of Cricket West Indies. Without further ado, thank you so much for accepting this invitation, Akshay. Really welcome you and look forward to your presentation.
Thank you very much, Peter, and thank you very much for inviting me. A real privilege, I assume that you're able to see the screen, the shared screen. And so just to point out that to summarize that long sentence of management of the frequently occurring injuries in athletes, I just summarize that to say common athletic injuries. And then we'll put in the sort of proviso that to go through all of them would take forever. So we're going to focus on special groups and special concepts. And thank God for Rhonda Hudson, who set the stage and sort of looked after all the emergency issues. But just to point out that amongst common injuries, one thing that you can divide sporting injuries into is acute and chronic. And obviously the acute injuries are those which have sudden pain. They're usually due to some sort of traumatic event or something that's taken place at that point, even though they may have underlying factors, risk factors. And we'll look at some of them as we go along. And as far as orthopedic injuries are concerned, you're looking mainly at the muscle, at ligaments, bone and joint. But then you also have to deal a lot with, probably more, with chronic injuries, which are lingering. They tend to present because the person has had them for a while, but now they're increasing in intensity. They may be predicated by a previous injury, and you'll hear this as a common theme, both in Dr. Hudson and my presentation. But the problem is that if they're not dealt with properly, especially in the acute scenario, then you tend to end up with scarring of tissue or shortening of muscles, etc. And that is what usually causes the chronicity to continue. Obviously, that has to do with muscles and ligaments. For the bones, the chronic fractures, so to speak, are the stress fractures. And for joints, if not treated properly and initially, then you may end up with laxity, such as in the shoulder. And these are some of the common injuries that we'll be looking on as we go along. But as far as muscle injuries are concerned, those injuries that are more likely to get injured, to get involved, are those that traverse two joints. So by far, that powerful muscle called the hamstring and its counterpart, the quadriceps, which traverse the hip joint and the knee joint, are susceptible, as is the gastrocnemius, which goes from the knee across or above the knee to below the ankle, and in the upper limb, to a lesser extent, the biceps brachii and the triceps. Ligament injuries are common in the knee, ankle, and wrist, and obviously you're going to see lower limb more often than upper limb because with weight bearing, those are more susceptible to get injured as well. And if you're looking at joints, then as I said, instability is more likely to occur in something like the shoulder. And this will probably form the basis of the talk today. I noticed that Dr. Hudson has spoken about ligament injuries in the 3 grades, and it's similar here with muscle injuries. And we're talking about strains or sprains, those are really synonyms. Grade 1 injuries of a muscle are where the fibers only are involved. In fact, if you're to cut open the muscle, you probably will see nothing. It's more a microscopic injury. And these usually resolve with rest, as opposed to the grade 2, which has a partial tear. And these two will resolve with rest. And I'll qualify rest in a second as to what I mean by that, but would probably require some physiotherapy as well. Grade 3, which happily are not very common, are complete tears of the muscle and may require surgery. But the important thing is that as you look on the right and you see what a normal muscle looks like, and you can see what a strained muscle looks like with muscle fibers disrupted and a bit of edema, if that is not allowed to heal properly, you end up with the bottom picture there of scar tissue, which is what leads to chronicity. Because if you look at the top muscle with lovely fibers, which are able to contract and expand, they glide. Scar tissue doesn't. And so if you stretch it, it tears, and that tends to cause chronic pain. So I'm going to focus a little bit on hamstring injuries, it being the most common muscle injury, and also will set the tone on approaching muscle strains across the body. As I mentioned, they traverse the hip and knee joints, and they're amongst the most powerful muscles in the body and are needed for propulsive sprinting. But they account for almost 1/3 of muscle injuries in athletes and almost half of the injuries in sprinters, especially in sprint hurdlers. The problem, though, is that if you get the first one, there's up to a 31% chance that you're going to have a recurrence of this injury. And so the important thing about hamstring injuries really is trying to prevent them. But we'll get to the prevention later. I'll just remind everybody the hamstrings really has to do with 3 muscles, all of which come from the ischial tuberosity, and they split to go on either side of the knee, so that laterally you get the biceps femoris muscle, and medially you have the semimembranosus and semitendinosus coming down, and the rectus femoris, of course. The muscles all come from the ischial tuberosity, and they go on either side but will obviously have sort of, you'd say, antagonistic action with the quadriceps muscles, which can also get involved. And in that one, the rectus femoris is the one that's most commonly involved. But as far as hamstring injuries are concerned, there are actually two types, two distinct pathologies. So it's easy to say hamstring injuries, but you're looking at a type 1, which is more associated with sprinting, as opposed to the type 2, which is more associated with stretching. And I'm going to just spend a bit of time discussing the two of them, bearing in mind that the biceps is by far the most commonly involved muscle in athletic injuries of the hamstrings. Now, the type 1 is associated with high-speed running and usually takes place distally at the long head of the biceps femoris muscle at the proximal musculotendinous junction. And so this injury, the type 1 injury, is going to take place at the point of least resistance, which is typically the musculotendinous junction of a muscle, of a large muscle especially. You will frequently see this in the mid portion of the muscle belly as well. It causes obviously the acute decline in function, but happily is quicker to recover, quicker to rehab. And if you want to get the sort of verbose version of it, then it occurs during the terminal swing of sprinting, when they're highly activated and work eccentrically to decelerate the swinging tibia with the knee inflection in preparation for foot strike. But since that's not easily digestible, let's look at Alison Felix here in the red and see what I'm talking about in terms of getting that injury. So just watch her coming around the corner there. And there she has the athletic pull, and that is where she goes down to the ground. And unfortunately, that is when it typically takes place, when you have maximal exertion, and that's usually in the competitive arena. The type 2 injury is more due to excessive stretch, especially when the hip is going into flexion, and is seen more with sliding, high kicking sports, splits, especially in things like gymnastics and so on. And this takes place proximally, usually at the free tendon, the free end of the semimembranosus up by the ischial tuberosity. The problem with these is that they take longer to rehab. And the closer the site of maximum pain to the ischial tuberosity, the longer it's going to take. So if it's right up at the origin, then that's going to take longer than if it's just at the musculotendinous junction or slightly distal to that. And it is seen in activities requiring large amplitude and ballistic limb actions. And once again, to give you a graphic presentation, here's Darren Sammy sliding after a ball. And as he gets up, you see that he's in some trouble. And if you watch him getting up, he stretches that right hip, and there goes the hamstring right there, the type 2 injury. It's totally different in etiology to what you saw with Alison Felix previously. So risk factors for hamstring injuries include strength imbalance between the hamstrings and the quadriceps or other muscles. And this usually is caused in pre-season training. And I spend a lot of time on that because in pre-season training, especially in adolescence, we see a lot of emphasis being placed on strengthening of the muscle as opposed to stretching of the muscle. And I say adolescents because they're going through a growth spurt where already there's a lot of stretch, a lot of pull on the muscle. And if you spend a lot of time just trying to bulk it up without stretching it out, you end up with a lot of imbalance and some shortening, which predisposes to hamstring injuries. Inadequate warm-up, reduced flexibility, which is in keeping with that shortening, and poor muscle strength, either proximal or distally, so that is poor core stability, or even fatigue and dehydration are predisposing factors to acute hamstring injuries. If you suspect this, especially in the acute stage, an MRI is not something you have to jump to immediately. The first thing you jump to, obviously, is the history, followed by an examination. You get a good idea of what's happening there. If the person is having mild pain, you can actually do some cross-legged bridges to accentuate the injury. But very often, this can be picked up on an ultrasound, which is very accessible, very accurate, and obviously quite less expensive, if you don't want to use the word cheap, than the MRI. The other advantage, of course, is that most sports medicine physicians will walk around with their own ultrasound machines, and therefore you can get an instantaneous answer, as opposed to those deep cases or difficult cases where you may then go on to an MRI. But honestly, MRI is not the be-all and end-all for hamstring injuries unless it is very, very deep, or if you need it for prognostication. The initial treatment, and here we go now. I heard a question being asked about rice versus price versus police. And the difference really is that there's protection, as you heard with price as well. So you want to initially protect the area, either by splinting or taking off weight bearing, etc., etc. But you don't want to hold that for too long if you don't have to. So if there's a fracture, clearly you're gonna have to splint it until this thing heals. But sometimes you have to actually do some optimal loading. And optimal loading is because we know that tissues respond to stress in healing. And respond to stress does not mean overstressing them. It does not mean trying to do normal activities when they can't manage it. But what you're talking about, for example, if you've got a grade 1 hamstring strain, you can start weight bearing when it's tolerable, because that stress is actually going to activate healing. There was a time when people had ankle sprains and they'd be put in a cast for 3 weeks. And that's been shown to be detrimental unless it's absolutely indicated. Because once again, if you're not moving and not stressing the joint, it does not heal as well. And when I say heal as well, I'm also talking about those muscle fibers not forming scar tissue. So you want to get early movement and a bit of stress as well. The rest of it of police is the ice, the compression, and the elevation, which obviously takes place immediately. So police is protection, optimal loading as soon as you can. And that doesn't mean immediate. And then, of course, immediate does include ice, compression, and elevation. And as far as hamstring injuries are concerned, if one is not able to walk within 24 hours, it means that the rehabilitation is going to take 3 or 4 times longer than those who can actually weight bear within 24 hours. And so something to bear in mind. There are other things you can use as adjuvant therapy. Hyperbaric chambers for those with hamstring or other muscle injuries has shown some advantage in return to play. I've had to use it once or twice in Jamaica. It, of course, means going to the Discovery Bay lab. But we've had series here. I remember a netball series where one of the overseas teams had somebody who had a hamstring injury. They're trying to see if they could get this person to play the last match of the series. PRP injections, and you might want to add to that stem cells, to some extent is the new noni juice, meaning it's a new buzzword and its indications are still evolving. It certainly has a role in medicine, but I don't think it has a role in acute hamstring injuries. It's not been shown to reduce the time to return to sport. And it can be discussed later. There's a lot to cover right now, but PRP injections really in acute muscle injuries is very, very debatable. And certainly the use of steroids is contraindicated because, as you know, that weakens the muscles and will lead to further injuries. So we remember we're talking about acute injuries here and that of the hamstrings. I'm going to quickly move on to knee injuries because we have quite a bit to cover. And we're just going to look at the common knee injuries. Obviously, it takes seen more in males. Mainly those in their 20s. The anterior cruciate ligaments is the most affected, followed by the menisci, and then you've got the collateral ligaments as well. But remember, those are ligamentous injuries. You can also have bony injury, you can have damage to the articular cartilage, and you can have dislocations to the knee. And you saw where Dr. Hudson had spoken about the emergency nature of knee dislocations, but please remember that the far more common dislocation around that area is patellofemoral. And that is not as emergent, it's not an emergency by any means, as compared to a proper knee dislocation. I may not have time to talk about the dislocations as much, and Dr. Hudson spoke about the emergency nature of knee dislocations. But also remember that when somebody presents with a knee injury, it can be something outside of the knee joint as well, like a quadriceps tendon tear, a patellar ligament injury, or even distal hamstring injuries. The injury may be retinacular, or it may be proximal, as I said, in the quadriceps tendon, or distal in the patellar ligament. As far as the knee ligaments are concerned, those are the most common ones inside the knee. And as I said, bear in mind, you can get articular injuries, you can get other injuries, but these are by far the commonest ligaments that are damaged in the knee. The collateral ligaments to the side, both medial and lateral, the cruciate ligaments inside, of which the ACL almost 95% of the times is damaged, and the menisci that we're going to spend some more time looking at in detail. You can also have combinations, the most common of which are in the posterior lateral complex. So I'm going to very quickly mention the medial collateral ligament tear because that's the archetypical ligament tear in terms of its healing. Now, when somebody has an isolated MCL tear, you're going to have tenderness immediately, but you're not going to have an effusion because it's an extra-articular structure. When you examine the knee, there's going to be some medial laxity if it's greater than a grade 1. The good news about it is that the grade 1 and the grade 2s heal fairly well on their own within 2 to 3 weeks. The grade 3, which if you remember, is a complete rupture of the ligament, will in itself heal by itself, usually taking much longer, about 4 weeks. Remember, we're talking about an isolated tear, not one which is combined with a meniscal tear or with an ACL tear, which will require treatment of those injuries. But the interesting thing about the ligament tear of the medial collateral ligament is that if you actually intervene with surgery and immobilization, that's been shown with a long-term consequence of valgus laxity as compared to if you allow this thing to heal by itself. And healing by itself usually means putting them in a brace, which prevents valgus displacement. And that's typically a hinged knee brace with metal stays on the side. And this will heal very, very well. So this is your archetypical ligament healing, which is totally different from the LCL injury, just on the other side of the knee, which in fact does not tend to heal very well, especially the grade 3, which will usually require repair or reconstruction. And the thing with the LCL tears is that you rarely find them in isolation. They're often associated with posterior lateral complex injuries. And the message here really is that if you've got an MCL tear in isolation, you can treat it on your own. If you've got an LCL tear, perhaps that needs to go on for further management with a sports medicine physician or an orthopedic surgeon. The LCL tear can either be mid-substance or it can be avulsion from the bone. But the point is that all of them, if they're complete, need training, need fixing. Menisci, which are probably the more commonly damaged ones when compared to the collateral ligament. Obviously, this is looking from above. Take the pressure off of the bone. So when you stand on them, they dissipate pressure. And they're typically damaged either by a twisting injury. So you have the foot planted and twisting of the knee on it, or they may be degenerative, even in sports, maybe especially in sports. They present in the acute scenario with knee pain, obviously a traumatic event, incident, but the effusion will not be immediate. The effusion typically takes place 4 to 6 hours later because it is in fact an effusion and not a bleeding, especially if it's not at the red zone, which is right at the periphery. There you have some blood vessels. But the rest of the meniscus doesn't have a lot of blood vessels. It's very poorly vascularized, and therefore it takes a long time for that inflammatory reaction to take place. They will typically present a few days later with the knee giving way, meaning they're walking, they turn, and the knee just gives way under them. And the treatment involves not just surgery, but very often just strengthening of the knee, especially in degenerative changes, has been shown to be as good as surgery. So if you've got somebody with a degenerative change, maybe somebody who's a bit older, strengthening of the knee may be all that they need to do. And if they're symptomatic thereafter, then you may have to do either repair or excision of the tear. As far as tears are concerned, you can get little flap tears like the one you're seeing here on the top left. You can get vertical longitudinal tears, and you can get total bucket handle tears. And their treatment really depends on what sort of tear it is and where it occurs. For example, this flap tear, which is very peripheral, the blood supply that comes from outside in is not very rich here, will probably do well with an excision. Whereas this tear that you see here, the vertical longitudinal tear, could take some stitches across it. And even this bucket handle tear, if you can reduce it and get it back in, you can put some sutures across it, and that will do very well. And and of course, there's this complex tear, which has to be assessed individually. But let me not just describe it, let me actually show it to you. So here is a knee, and we're going to go through 2 pathologies. That's the patella. We're going down the lateral gutter, and the first thing I'm going to show you is just a normal meniscus that you see me probing here. This is the normal side of this particular athlete. As we flip over to the medial side, and there you see the flap tear coming out there. And if you can imagine, that flap, when the person stands on it, causes a lot of pain. And so in this scenario, we just had to go there and excise it. And once you've taken it out, you realize it's not going to come between the bones when he stands up. And that person did very, very well. As opposed to this normal meniscus, and here's your bucket handle tear. The meniscus is sticking out, and the first thing we do is to reduce it. There it goes, flips in. And because it's stable, we can now put some sutures across it. And so you're going to see the suturing technique here, where we actually attach it to the posterior capsule. And once that heals, that's going to do very, very well. But the difference is for this to heal, it's going to keep the person out of sport for about 4 months. They're going to be immobilized for about 1 month. But the risk of getting arthritis afterwards, osteoarthritis, is no different than a normal meniscus once this thing heals. Of course, there is a risk of it re-tearing, but usually they do very well. And you can see after we put in those sutures, I'm probing the ends, and you can see the sutures there, and this is very, very stable. Once it's healed, in 4 months, when I say 4 months, 1 month in immobilization and progressive physio, usually between 4 to 6 months, this person is back into active sport. So the meniscal repair usually is for younger players who have those more amenable to healing, those in the red or the red-white zone of the meniscus, even though you can actually do them in white zones as well. It's in a reducible meniscus, which has a repairable pattern. As I mentioned, there's longer rehabilitation. The person is out of sport for about 4 months, but the chances long-term of getting osteoarthritis are much less than if you excise that tear. So the approach to meniscal injury is that of a history of twisting with delayed swelling. If the person has locking, which means that they're not able to straighten out their knee, then that requires immediate surgery. Otherwise, they'll walk and they'll give you a history of giving way. On examination, they may have a positive McMurray test, and I say positive because it's only positive 30% of the time. And in fact, it's only reproducible 30% of the time. So if you get it the first time, you may not get it the second time. My approach is that maybe not in an elite athlete, but certainly in a recreational athlete, I might actually just give them 2 weeks of rehab to see how it pans out, do a bit of strengthening, and if it's not getting better, then I'll move to an MRI to make a definitive diagnosis. In an elite athlete or somebody who needs to have immediate treatment, I'll go straight for the MRI. So the elite athlete, for obvious reasons, because you want to be able to prognosticate, it doesn't mean that you'll necessarily go straight to surgery. If that injury can wait till the end of the season, I may do so. But for example, even recently, I've had young athletes coming to me who are about to go off on scholarships to universities overseas, and we don't have time to wait. We need to know if it's an injury. We need to fix it now because come August, they need to be ready. So obviously, things change depending on the circumstances. But if there is a tear and it's symptomatic, then that's going to require arthroscopic intervention, as we just showed you a while ago. A brief word on ACL tears, which are far more common, is that this can take place with a contact or a non-contact injury, far more common in females. And this one does present with immediate swelling, usually a hemarthrosis. They will have a positive drawer or a Lachman's test. And if it is torn, it usually requires reconstruction. Not always, not all ACL tears require reconstruction, but certainly in the young athlete, it is highly, highly recommended. I'm going to briefly just show you the Lachman test since a lot of people hear about it. This is a test where I tend to put a knee just below the distal femur because it allows me to put my hand over the distal thigh and cup the proximal tibia and then look for that laxity in the knee, which you can see taking place there. You can see a lot of giving going forward, and this is a positive Lachman's test. So with that knee underneath, you get a lot more stability and you're able to perform this much better even if you have small hands. So in summary, if an athlete presents with knee pain, the question is, where is the pain? Is it in the knee or outside of the knee? Do you have swelling? And if so, when did you get the effusion? Are you able to extend it or not? Because if it's locked, it's an emergency. Is it giving way? Are there signs of an effusion? Is there tenderness? What is the status of the collateral ligaments through varus or valgus laxity testing, the cruciate ligaments with the Lachman's and the drawers test, and the McMurray test for the meniscus? And there are many other meniscal tests. All of them are probably equally not good. I'm now going to move on to leg pain, which once again, don't have the scope to spend too much time on it. But obviously, if it's an acute muscle injury like calf injuries, it follows the same suit as we mentioned before. I'm going to mention 4 common causes of chronic leg pain that may present to a general practitioner or present by an athlete to a sports medicine doctor. And those are anterior tibial periostitis or shin splints, stress fractures, chronic compartment syndrome, and tendinitis of the lower limb. Sorry, I think I've gone backwards. Where am I? So the causes of chronic leg pain can be due to many factors, which are intrinsic or extrinsic. So when you're actually treating them for leg pain, you have to look at, do they have flat feet or foot pronation that might be causing abnormal stresses? Is there muscle weakness, decreased flexibility? What's the biomechanics like? Just watch them walk. Let them do a one-legged squat. More common in females with higher BMIs, and more common with those who have increased external or internal rotation of their hip. People who have been overtraining and are fatigued or have errors in their training have improper shoes or improperly fitting shoes. And those who run on hard surfaces as opposed to fields, etc., can all present with this chronic leg pain. One of the common ones that I see in football and cricket, for example, are those who have played in places in Europe and then come back to Jamaica. And so they've been playing on softer grounds and they come back to Jamaica and play on harder grounds. And you find that they have problems with chronic leg pain. Now, shin splints, which is properly called anterior tibial periostitis, was previously called medial tibial stress syndrome, is due to excessive pull of the muscle on its bony attachments, usually the tibialis anterior, and is felt along the inner border of the leg, mainly when the person gets into running for a while. The pain is felt along a long longitudinal portion, either anterior or posterior, along the tibial edge, and is relieved with rest. On examination, therefore, you will have tenderness along the tibial border, and if you do an X-ray, you're not going to see any change. But on a bone scan or an MRI scan, this will light up as a long area of involvement. And the treatment, obviously, is to look for those things which are causing problems, like the muscle imbalance or the shoe or foot improper gait, and treat that. But immediately, you're going to have to start with relative rest, meaning that they're not to start running, but they can continue walking if it's not causing pain. They can do some strengthening work, which doesn't cause pain. You can try to offload them with taping, with insoles, with massages, especially ice massage. Start some flexibility exercise, and that's especially if the person is in the middle of a season and you're trying to get them through till the end of the season. They will require usually biomechanical adjustments to correct some of the extrinsic factors. This is in contrast to a stress fracture where you have point tenderness on the tibia, which, as you can see on this bone scan and on the MRI scan, is just a small area of involvement on the bone. That point tenderness, once again, comes with the same sort of history of running, having pain while they run, but it's relieved at rest. And once again, the bone scan or the MRI is the investigation of choice. In this case, you want to immobilize them until they're pain-free, and that means usually on a pair of crutches. And it rarely requires surgery, but there are some instances in which you do have to do surgery on a stress fracture of the tibia. Chronic compartment pain syndrome, again, presents with swelling in a with pain when they start running. And this is accompanied by swelling now. So they get severe swelling of their calf usually, but it could be any of the compartments of the leg. And once again, when they rest, that swelling goes down and the pain goes away. This you can diagnose by getting them to run, getting them to really get this thing swollen, and then measure the compartment pressures. And usually it requires myofascial release, but you can try to get them through their season by doing measures like ice massage and other things. But if it's really painful, then you're going to have to stop them from running and do a myofascial release. Tendinitis, however, of the lower limb is slightly different. This is one in which they're not having pain. When they start running, it hurts a bit, and then as they run, the pain goes away. But then when they rest, the pain comes on. So this is total contrast to the other three we saw. And typically, this gets better with this can be picked up with ultrasound and requires some alteration in their training schedule and physiotherapy to get better. So in the interest of time, I'm just rushing along to the common injuries, and we're going to move on to ankle sprains, which happily was looked at in detail in its acute setting by Dr. Hudson. So all I can add is that it accounts for about 30% of all sports injuries, and almost half of the ankle sprains occur in sports like netball, basketball, etc. And this is more so since moving on to those indoor courts, we're seeing a lot more on the wooden surface, we're seeing a lot more ankle injuries as opposed to the hard court where we used to see a lot more knee injuries. I'm not going to spend time on the common ankle sprain, but just to mention that there is a high ankle sprain that you have to be aware of. And that high ankle sprain occurs where you have not just the typical medial or lateral ligaments being damaged, but also the syndesmotic ligaments being damaged, with external rotation force in a dorsiflex ankle, and that causes separation of the fibula from the tibia. It requires disruption of either the interosseous ligament with either the anterior or posterior tibiofibular ligament. And I mention that because this is the less commonly seen one. It has a high diffuse pain, so pain in the proximal part of the ankle with tenderness. And when they have this, this takes much longer to return to play. They have a positive squeeze test when you squeeze where the right hand is. They also have pain on external rotation stress that you see the person doing themselves with their left hand. And that's called the cross-leg test. So there has to be a high suspicion for the high tibial ankle sprains, and you have to look out for fractures as well. And I mention this because the common ankle sprains obviously are spoken about quite often, but here's one that people sometimes forget about. Now, not all ankle sprains require an X-ray, and as we had mentioned before, I think Dr. Hudson had spoken about the acute injuries. There are some rules to guide us, and more importantly, to prevent us from being sued if we don't do an X-ray when they don't have any of these signs and symptoms. And I say that because there was a mass wastage and exposure of X-rays to people by just doing ankle X-rays with any ankle injury. So now, of course, if the person has tenderness along the posterior edge or tip of the lateral malleolus, base of the fifth metatarsal, where you can have your avulsion injuries, tenderness along the posterior edge or tip of the medial malleolus or the navicular, or if they have inability to weight bear immediately or a few days afterwards or a few hours afterwards when they come into the emergency department, then obviously you need to get an X-ray done. And on a lighter note, I'm just going to point out something from Dr. Hudson's speech. She did tell you that PPE meant pre-participation evaluation, but in this COVID era, it means something else. But she kept mentioning ED. And in this COVID era, I just want to point out that when she was saying ED, she actually meant emergency department. So if the person has pain on walking either immediately or coming into the emergency department, they're not to, that warrants an X-ray. Once again, the treatment is like with any other ligament treatment. Acute injuries require protection, optimal loading with icing, compression, and elevation, relative rest with early motion, physiotherapy, and once again, look out for intrinsic factors, especially foot imbalance. If it's a chronic ankle injury, this typically requires an MRI and further intervention. I'm now going to rush into upper body injuries simply because lower body by far is the predominant part that is injured. And just to point out, whoops, we've got something on a timer here, that upper body injuries are dependent on age. And when I say age, if you've got children, they're more likely to have physeal injuries. Adults require, and when I say adults, I mean skeletally mature adults, require a lot more trauma. And that injury is more likely to be diaphyseal or dislocations or avulsions. Whereas the elderly are more likely to have metaphyseal damage across osteopenic or osteoporotic bone. The other thing that determines where it's damaged is the mechanism of injury. If it's direct trauma or if it's fall from a height, and also the direction of the fall. And here's a listing of all the things that can get injured when the person falls on an outstretched hand. And all I'll point out is that can be any bone from your finger bones right up to your clavicle, and it can be any joint in the upper limb. So if somebody falls on the outstretched hand, obviously you've got to examine the entire limb. Fractures, I'm going to specify a few common ones. Phalangeal fractures, if they're intra-articular, obviously will require surgery. But if they're extra-articular, you've got to align them properly, because if there's any malalignment, it's going to leave with rotation. So you see this spiral fracture here, which you may think is innocuous, but if you don't actually get proper alignment, you end up with this sort of a problem where the little finger is swinging in underneath the ring finger because of a malrotation. And so typically you want to maintain the length, you want to maintain the alignment, and using a buddy splint, which means you tape it to the finger next to it, will ensure that alignment. You can also use an aluminum splint, but that will prevent movement, and therefore you don't want to keep it on for more than usually a week because you want to get early motion in the finger. So if you do have a fracture like the one you see here, which is a spiral diaphyseal fracture, this is actually very unstable and may benefit from 2 screws or some wiring. Scaphoid fractures are by far the commonest fractures in adults. They require a lot of energy, and because they're cartilaginous, they don't necessarily present on an X-ray, especially immediately. In fact, you may have to delay taking that X-ray for up to 2 weeks. Therefore, you need a high index of suspicion if somebody has snuff box tenderness. And as I said, if you suspect it, put them in a thumb spica and repeat the X-ray in 2 weeks, or get an early MRI, because that will show it. If it's displaced, it requires surgery. I move quickly to distal radial fractures to point out that the amount of times that we tripped over, whether it's a Colley's fracture, a Smith's fracture, or Barton's fracture, is now extinct. That was pertinent when you didn't have X-rays and therefore became extinct in 1903. By the way, these descriptions were done in 1845 when they had to treat based on what the hand looked like. Now it's more important whether this thing with the distal radial fracture is extra-articular or intra-articular, and whether it's displaced and reducible. And as I mentioned before, if it's somebody who's young, then it's going to be a physeal fracture, a Smith, what you call I've got a mental block, a Salter-Harris fracture, sorry. If it's an adult, then you have a lot more energy taking place, and they tend to have comminuted fractures. And in the old people, it's minimal trauma, and they can have intra-articular or extra-articular fractures. So if the fracture is undisplaced, usually all you need to do is to immobilize it. If it's displaced, then you try a closed reduction and see if it's stable. If it's stable, it needs a plaster. If it's unstable, then you might just have to stabilize it with some wires and maybe even an external fixator just to maintain the reduction. Open reduction internal fixation, therefore, is reserved for those fractures which are irreducible or intra-articular and irreducible or have shortening involved. I move quickly then to the shoulder to point out once again that as far as dislocations in athletes are concerned, the most common one is shoulder dislocation. And I'm not going to spend too much time on it because Dr. Hudson had spent a lot of time talking about it, but just to point out that the dislocation can be either due to a direct hit on the shoulder or due to a lever arm action, and that anterior dislocations are by far the commonest. The investigation of choice is your transscapular X-ray, which gives you what calls the Mercedes-Benz sign, looking like this, or if you look at the X-ray, looking like this, where what you have in front is the coracoid process, what you have behind is the acromion process, and in the middle is the glenoid. And so this is a normal transscapular view. If the injury is posterior and therefore underneath the acromion, then you're looking at a posterior dislocation. More commonly, that the humerus is below the coracoid, and therefore what you're looking at is an anterior dislocation. And clearly that is something which requires immediate attention. But sometimes athletes will have subtler conditions, and that could be with recurrent dislocations or subluxations. The slipping out of the joint, or the sensation is going to slip out, which is associated with labral tears. They can also have impingement. When they move their shoulders, they can have either impingement of the bursa, the tendons, or the rotator cuff. And when I say tendon, it can be the supraspinatus tendon, which is an external impingement, or in throwing athletes, it can be the biceps tendon, which is an internal impingement. And of course, they can have rotator cuff tears. Once again, for impingement injuries, the ultrasound is excellent, and one doesn't have to rush to an MRI. But for instability, an MRI with an arthrogram is the investigation of choice prior to doing arthroscopy, which usually ends up being required. And so the last thing that I was asked to speak about was back pain or back injuries in athletes. And once again, I'm not going to talk about the traumatic injuries, which would have been covered, but just to point out that back pain in general can be spondylogenic from the spinal column. It can be neurogenic. It can be vasculogenic, viscerogenic. And if it's none of that, it can be psychogenic, which has to be a diagnosis of exclusion of the others. And this doesn't escape athletes either. So not all back pains in athletes is because of something in the spinal column itself. But obviously most are. And therefore, we have to look at whether they've got local pain, which means that the pain is just in the area, it doesn't radiate, it doesn't have any neurology associated with it. And in athletes, it's commonly seen with people who have got spondylolysis or spondylolisthesis, injury or degeneration of the facet joint, or stress fractures or stress reactions, which are early forms of stress fractures. If they've got radiculopathic, which means pain radiating down one limb usually, with numbness, tingling, and weakness, then you're looking at nerve root compression, usually from bulging or prolapsed discs. Or if they've got bilateral pain with upper motor neuron signs, such as hyperreflexia, a bit of wasting of the muscles and so on, then you're looking at compression of the cauda equina, which may be due to stenosis or due to central disc protrusion. And of course, you can get a combination of all of these. So for those persons that you're seeing with local pain, you obviously want to get a history of the fact that it's not radiating. And you may get a positive quadrant test if you stress the facet joints, or a hyperextension test if you're looking for stress fractures. And unfortunately, in the interest of time, I'm just mentioning these tests. We'll have to do a whole session on what these tests are if we want to demonstrate them. For those with radiculopathic involvement, the straight leg raising and slump tests are usually diagnostic. And for myelopathic injuries, you combine all of this with neurological testing, and you'll see signs and symptoms of myelopathic involvement. So the X-ray is usually good for persons you're suspecting with spondylolysis, spondylolisthesis, scoliosis, and things like that. A CT scan or MRI is excellent for stress fractures. The MRI is better because it actually shows you whether it's active or not. And a bone scan is also good for stress fractures. The MRI is a great investigation, but sometimes it is just too sensitive, meaning that if you look at this person who has a disc protruding here on the right, that person is totally asymptomatic, does not have a problem, and therefore does not to be treated. And this MRI probably did not need to be done on that particular person. So the X-ray, as you can see here with the spondylolisthesis, where you can see that there's a step in the L5 compared to the L4, will obviously be seen on an X-ray. A bit more severe here. Stress fractures on a CT scan will show you that fracture line, which can be followed up to show you full healing. And of course, bone scans will light up if there's any facet joint involvement or stress fracture in a particular vertebra. The MRI, therefore, which is a very sensitive test, but I want to point out that it has a lot of the sensitivity causes a lot of things being picked up that may not actually tie into your history or examination. The MRI should therefore be reserved for people who are not resolving with adequate therapy, or who are getting worse with therapy, or have what I call ambiguous anatomy, meaning that they're just not making sense. The history is one thing, the examination is showing something else, and it's just not making a diagnostic sense. Well, you can do your MRI there. Very often you'll find things like tumors, for example. You may also use the MRI for prognostication, especially in elite sports people, who you've got to make a call whether this person needs to be pulled out of a match, pulled out of a series, pulled out of a season. They obviously will require MRIs a bit earlier. So in concluding, common injuries that present to the GP, all I can say is that, like in everything else in medicine, do no harm. We've got to treat them depending on their sport, depending on the circumstances. And I'd like to share with you a quote that my own cricketing mentor shared with me throughout my childhood. George Headley used to tell me that the sign of a good batsman is knowing not what shot to play, but knowing which ball to leave alone. And likewise here, it's not which one you can treat, but knowing which one you need to pass on to a sports medicine physician or an orthopedic surgeon. Thank you very, very much. Over to you, Peter.
Thank you so much, Akshay. That was a fantastic presentation, very clear, very easy to understand. It gives me a lot more confidence now to go and treat and to refer the necessary injuries. I'm sure there'll be lots of questions, so let's move into the question and answer section. And I'm going to ask Sam if you would to help me again. Thank you so much.
No problem. Thank you. Great presentation. First question is from Dr. Taylor. How safe is repeated MRIs for injury?
Well,
it's a four-part question.
Radiation with an MRI, it's magnetic. And to date, there's no evidence of any long-term sequelae of MRIs. And therefore, you'd have to say it's safe to the body. It's not very safe to the pocket. And therefore, you know, once again, it should be done if it needs to be done. And obviously, it's one of the best investigations we have out there. But I keep promoting that an ultrasound machine with a musculoskeletal radiologist or sports medicine physician sometimes does as much or even more than the MRI. And the last plug for ultrasound is that it's also a dynamic study. So when I'm looking at a muscle, for example, I can see that muscle moving with an ultrasound, whereas you cannot see that in an MRI, and therefore it can also help you too. So the MRI is a safe investigation.
Part 2 of the question, in spite of latest investigations on management of chronic pains, how often are you seeing clients who, so to speak, need to live on anti-inflammatories?
You know, I have a pet peeve with anti-inflammatories. And in fact, for years, I've gone around giving talks on the use of NSAIDs in sport. Long before we got the black box labels, so that's what I call it, black box labels about the side effects of NSAIDs with prolonged use on the cardiovascular, renal system, and even the liver. I don't really personally see an indication for long-term use of NSAIDs in sporting injuries, be it acute or chronic. There are obviously those conditions like rheumatoid arthritis and so on where it may be indicated. Otherwise, I think you need to find out if it can be treated. And what I mean by that is that in those people with chronic pain, we need to find the cause. And sometimes it requires some other intervention. And I did mention PRP not having a role in acute muscle injuries, but they do have a role in chronic injuries. There's a role for deep tissue massage and a lot of other physiotherapy modalities. When I say modalities, I'm not talking about ultrasound, but I'm talking about actual manual stuff. There's a role for surgery in some scenarios. But anybody who's persistently on NSAIDs, we've got to find out the cause and deal with that.
Awesome. Part 3 to the question. In your opinion or experience, how effective is stem cell treatment of inflammation?
I don't think that there's an indication for acute inflammation and stem cell treatment. And remember, stem cell treatment is highly evolving, shall we say. I personally believe, by the way, that it's the treatment of the future. I think at some stage we'll be able to identify the factors in stem cells and get them, along with genetic modifications, to treat a lot more conditions than they are right now. So I'm not trying to disregard them at all. In fact, I have used them. I've used them in chronic, severe osteoarthritis. I've used them for some other conditions, but for inflammation, I don't know if there's strong evidence for it. Those who use it will tell you a different story. PRP likewise has some indication, but I don't know if it's very strong. Let me just take one step back by saying that as far as stem cells and PRP are concerned, I personally need to understand the science. So when I know that you cannot regenerate hyaline cartilage, I find it very difficult to digest that if I inject stem cells and I inject PRP, I'm going to regenerate hyaline cartilage. So if you tell me that you're going to regenerate fibrocartilage to replace the hyaline cartilage, I then understand. And okay, let me plug the pothole with something, which is fibrous cartilage, but I'm not going to get hyaline cartilage. Likewise with muscle fibers and with other specialized tissue. What the PRP will do, obviously, is take growth factors there, and so will stem cell. So does bleeding, so does blood. So let blood do what it's doing. And if you need to augment it with factors, that's fine. So I will certainly not promote it for acute management, and there's no evidence to show that. And I'll say be very careful when you're doing chronic management by first doing, treating things with physiotherapy and so on. But where I do use stem cells and PRP is in chronic Achilles tendonitis, especially enthesopathies, that's at the insertion, in chronic patellar ligaments or quadriceps tendonitis, so these are the large areas, and in shoulder problems with rotator cuff even tears and rotator cuff injuries. So those are where I tend to use it more often.
And part 4 to Dr. Taylor's question, is a pop cast indicated for plantar fasciitis at all?
A POP cast.
A POP cast, yes.
Yeah, well, immobilization in general is not recommended for anything more than fractures these days. And that's because you've got such excellent splints available that you can actually utilize them. And there are many plantar fasciitis splints that I find very, very useful. In fact, if you look at plantar fasciitis splints, you'll see about 100 different varieties, which means two things: that no one is good, and that there are different, sort of severities. I do use the plantar fasciitis splint for very difficult plantar fasciitis. The advantage of splints, of course, is that you can take them off. So you can bathe and you can do physiotherapy and you can do icing. And the disadvantage of a splint is that you can take them off. So if you don't have a very disciplined patient, then obviously they can take them off as well. So you've got to gauge your patient. So a POP, I think, would be very, very limited in its use in plantar fasciitis. However, there are other adjuvant therapies like shockwave therapy and so on that I find very useful in plantar fasciitis as well.
Perfect. Dr. Arnold Brown Morgan asks, is there any role for CT scans in joint and limb investigations?
Very good question. CT scan generally is very, very good for looking at bone. And remember that the radiation of CT scan is very much greater than an X-ray, and certainly more than MRI for obvious reasons. But if you're looking for bony issues, so if you're looking for even small stress fracture lines, if you're looking for small tumors, the CT scan is very, very useful. But even for stress fractures, for example, an MRI looking at the bony architecture is very accurate. Plus, the fact that it lights up when it's acute is an add. I think that the MRI is probably preferred in most circumstances and may even be done in conjunction with a CT scan. So a CT scan, unless it's a complex fracture, or if you're looking for something bony, I think that's really the indication for it.
Thank you so much. Dr. Cargill asks, which are the radiology centers that do ultrasound for muscle injuries?
I can't advertise radiologists or radiology centers. You've got a few persons. Let me put it in perspective. And I'm going to call some names because I think they're the forerunners. Dr. Richard Bullock and Dr. Sandeep Shah are two radiologists that I find are fantastic with musculoskeletal work. And I call those names not to advertise them, but to share something with you. They, like myself and like Dr. Hudson, teach at the university. And therefore, it's our responsibility to make sure that every other sports medicine physician, or in their case, radiologist that comes out, is strong in musculoskeletal work. And therefore, I would like to say that every radiology center must have somebody who has adequate insight into telling you whether A, they can do it, and I think most can, or B, who they can send you to. But I would like to say that most of the new people would have a good insight into musculoskeletal radiology.
And Dr. Arnold Brown Morgan asks again, when and in what conditions is deep tissue massage efficient?
So I think we've got a presentation by a physiotherapist coming up, and I don't want to obviously, sort of steal your thunder. But what we look, what heals is blood. I mean, that's the bottom line. And so very often when you've got scar tissue and so on deep in a muscle, and you do deep friction massage, what you're really trying to do is to break down that tissue and cause some bleeding. When you're using ultrasound, for example, which is not very often used in sports medicine, I'm talking about therapeutic ultrasound, which honestly in modern sports medicine has very little role. All that's doing is taking heat and trying to deliver it at a lower level so that you can get more blood flow and therefore you can get more inputs. When you use heat, you're trying to do the same thing at a more superficial level. So deep friction massage really is trying to break down tissue and trying to promote a bit of bleeding in the area, but I leave the details to the physiotherapists who follow.
Thank you so much, Dr. Mansingh. That's it for the questions. There was a request for your presentation. If it is something that you can share, I'm going to ask you to share it with Lynn at AGPJ so she can put it together with the other presentations. Absolutely. And we can send it to all of our attendees. Dr. Swaby, over to you.
Sure, that I will. Thank you.
Again, thank you, Akshay. Thank you so much for taking the time to explain these issues to us. It is invaluable, and we are grateful for your input, and we're thankful that you're the head of the Dean of the Faculty of Sports.
Thank you very much.
Thank you again. At this time, we are going to have a second presentation from Sanders, as they're the session sponsors, and then we'll move into session 2 with Dr. Joan Rattray. Okay, so over to you, Sam, and to Sanders.
All right. Thank you so much, Art. So Shane, I'm gonna ask you and Christopher to unmute again, and then we're gonna share screen. Perfect. All right, we're seeing you, Christopher. So now we just want to share screen.
All right. Good morning. Are you seeing my screen?
Not just yet. I'm hearing you though.
Okay. Screen broadcasts. All right. How are we now?
Wonderful. So now we just need you to find the presentation and we take it from there.
Okay, great. All right, moderator, president, board members, and guests on the platform. Thank you again for the opportunity. My name is Christopher Beecher, medical representative with Sandoz, primarily focusing on the cardiovascular line, but today I'll be just reminding you on our robust antibiotic portfolio. And in keeping with the theme of sports medicine, we know that a lot of times on the pitch, athletes will experience trauma of various kinds, which could follow into secondary bacterial infections, especially those which actually occur on the field. And, you know, pathogenesis is very possible in terms of mixing with dirt, etc. So what we have for you in terms of treating your athletes would be our broad spectrum coverage of amoxicillin and clavulanic acid in our QRAM. And we have a very wide range of presentations. One of the widest range where amoxiclav is concerned on the market, we have our 625, of course, and as well as our 1 gram presentation. And for children, we have a host of suspensions ranging from 156.25 in a 100 ml presentation, or 60 ml 312.5, and also our 312.5 coming as QRAM Fort in a 100 ml. And one of the more popular dosages you will know as our QRAM 457 per 5 ml. All right. So just want to remind you in terms of broad spectrum coverage, in terms of beta lactam inhibition, QRAM is one of your best choices out there. It's widely accessible and very affordable. All right. Moving on, not so much sports related, but we do have in terms of patients who do suffer from upper respiratory tract infections, which is very common these days. In terms of the cocktail in treating your patients, we have our azithromycin benazit. And in the macrolide class, it's very convenient. And for patients, especially who have issues with compliance, it's only 500 milligrams of the benazit once a day for 3 days. And we also back that up for your pediatric patients with our benazit suspensions in a 15 ml and the 30 ml, depending on if you want to dose for 3 or 5 days in this convenient packaging. Again, widely accessible and very cost effective, and asking you to consider the benazit as a first choice whenever you need to prescribe azithromycin. Also in our antibiotic portfolio, we have our levofloxacin Sandoz, 500 milligrams, of course, for treating your otherwise lower respiratory tract infections or your PIDs, depending on what you're seeing. We're conveniently packaged with 7 tablets in the box. And of course, we offer flexibility of our levofloxacin Sandoz in that the tablet is actually scored. So it gives you as the practitioner the ease of stepping up to 750 or stepping down based on how you see it necessary at a more affordable cost than other brands that come in the straight 750. So levofloxacin Sandoz does offer you that ability to step up or step down conveniently and cost effectively because of its scoring. So asking for your support in our levofloxacin Sandoz whenever you see those patients come in who have the appropriate indications. So once again, reminding you of our antibiotic portfolio, we have the QRAM and the full ranges there, or benazit or azithromycin, as well as our levofloxacin Sandoz. Now, I want to turn your attention to another drug that we do have at Sandoz. It's fairly new, and one of the great things that we have coming up is our launch for Divinis. Now, this will actually take place on April 29th at 7 p.m. We'll send forth the invitation. So we're just asking you to clear your schedules so that you can participate in our Divinis launch. Our speakers will be Dr. Mark Taylor and Dr. Frey. And so we'll actually take a deep dive into treating patients who do suffer from chronic venous insufficiency as well as acute hemorrhoidal attack. Now, as you can see here, from time to time, you'll have patients who suffer from swelling, cramps, edema, which is, of course, related to venous disease. And so diasmin and hesperidine has been proven to reduce all the signs and symptoms, of course, with lifestyle changes. And one of the things that we want to look at is in terms of the CHEAP classification, we know them from C0 all the way up to C6, from patients who do have no visible signs of venous disease to patients with the reticular veins, patients who, of course, they have the edema, people who have the cutaneous or subcutaneous changes, as well as healed venous ulcer to active venous ulcer. One of the things we have noticed is that with the use of diasmin and hesperidine, patients who have suffered from these particular symptoms have actually moved from CHEAP classification classes 3 to 4, 180 days when administered with diasmin or hesperidine. So the proof is in the pudding. And I want to just remind you that Divinis is a very viable option, coming in at 500 milligrams BD dosing and coming in at a very cost-effective price of only $1,400 for the month supply on the NHF. That's right, it's covered on the NHF. And so when you compare this to other diasmins on the market, we are coming in at exactly 50% price reduction when you compare to the reference product, right? So again, some of the benefits of the Divinis would be increased red blood cell flexibility and velocity, of course, improving vein tone in patients without without any disease condition. And of course, it will definitely release venotrophic conditions. Also, the most important thing in writing the Divinis and remembering the Divinis when these patients do come in is that it will definitely improve the patient's quality of life. So with that said, I know that I've whet your appetite, and a lot of people probably don't have the experience with the Divinis just as yet. So just asking you to mark in your calendar April 29th at 7 p.m. The invitations will be sent, and we're looking forward to all seeing you. So once again, thank you very much for your support.
Hey, thank you very much. And we are on schedule thanks to our presenters and to our sponsors. We resume at 12:15, at which time Dr. Joan Rattray will be our moderator for that session. Thank you, Sam.
Thank you so much. A little bit of mood music while we're out. And as Dr. Swavey said, we commence at 12:15 p.m. So go ahead and have that snack. Refresh yourselves. A lot of information so far and a lot more to come. Thank you, guys. All right, so it's 12:14, almost 12:15, and we want to thank Dr. Joan Rattray for being here and to be part of this wonderful day, the presentations, and to lead our second session as moderator. Dr. Rattray, over to you. Have a wonderful session.
Thank you very much, Samuel. Well, welcome back, everyone, to part 2 of our virtual conference in sports medicine. And I am Joan Rattray, and I am a physical therapist, but I'm also a part of Jamaica Association of Sports Medicine. Our next 2 speakers are also members of this association, and it gives me great pleasure to introduce them. So far, I know that we've been provided with a lot of very useful information on injuries and on managing them, whether they be in emergency section or just knowing what sort of injuries may present at your office. Coming up next is Dr. Wynne Jones. And Dr. Jones is probably known to most people in his capacity as an orthopedic surgeon, and more recently has gained a bit of celebrity status through the many interviews on the radio and television regarding return to sport protocols during this COVID-19 period of the pandemic. As well as, for those who may have seen it, he was a recipient of the Certificate of Merit Award for Medical Services at the 2020 RJR Gleaner Sportsman and the Woman of the Year ceremony.
I'm sorry, Doc. Sorry to interrupt you. I think the agenda has a presentation from Indus Life Sciences first. And that would be Ashley Baldwin from Indus. Apologies.
All right, sorry, I didn't realize that. Okay.
No. I think maybe an amendment to my agenda. Apologies. So if we could have Indus go ahead, that would be great.
Sorry, please go ahead, Indus Life Sciences.
Sure. So Ashley, are you there?
Yes, I am. Thank you, Sam.
Sound a little bit low. I don't know if that's me. Go ahead again.
Good morning. Good afternoon.
Hearing you wonderfully. Yeah, man.
Great.
Go ahead.
Great. Good morning.
Good morning. Afternoon.
Good afternoon. Let me share my screen. Kindly hold with me, please.
No problem. Yep, I'm seeing your screen.
Great. Thank you. Good morning, AGPJ. I am Ashley Baldwin from Indus Life Sciences. And this morning, I'll be talking to you briefly about our brands that cover on pain management and pain recovery. So one, we have our brand called Capsitop. And in Capsitop, we have in it a SWAT team. Capsitop is our over-the-counter NSAID that consists of capsaicin, diclofenac, levomenthol, methyl salicylate, and it's a gel-based formulation. So capsaicin inhibits some substance P in the body that, of course, whenever there's a nervous pain, it gets released. And diclofenac, of course, prostaglandins. Salicylate, of course, by the interleukins 1 and 6. So our SWAT team, as you can see there, it gets to the point and takes out and wipes out all the pain precursors. And with our Capsitop, it's again over the counter and a gel base. So it goes into the muscular membrane as fast as possible. So it covers for not only, let's say, muscular pain, but also muscular, joint, and nerve pain suppression. So your knee pain, your wrist pain, back pain, neck pain, shoulder pain, spondylitis. And as Dr. Hudson said earlier, not only do we get pain during sports injury, but also in free time, right? So persons who, let's say, who carry those heavy bags, or those persons who walk long hours on the wall and your feet are hurting you, that same muscular and joint pain, rub can be used as well. Also, our GPs and gynecologists recommend it for persons who have back pain during their menses. So that's one of our indications. And it comes in a 3-gram tube. So it's easy to carry in your handbags or in your bags of choice. And it can be used, 1 gram can be used 3 times per day. And we say for this muscular rub, wash your hands afterwards because it contains capsaicin, which is some pepper, right? So if you don't wash your hands afterwards, that residue on your hands may get into your eyes or anywhere else, and it will cause more pain. And you don't want that, right? And continuing here, you can see you have a physiotherapist being protective of their patient. And at the same time, you see that the patient is having a relationship with pain. But we don't want that, right? As physiotherapists or doctors, we don't really want that. We want to have our patient not in any tie with any pain whatsoever. And what can stop that is our Capsitop. It stops the pain. And next is our brand that deals with pain recovery or body recovery in all aspects. And it's based on amino acids and multivitamins. And you know, of course, we have 10 essential amino acids, which are histidine, arginine, tryptophan, valine, threonine, isoleucine, leucine, lysine, phenylalanine, and methionine. And in it contains branch chain amino acids as such, right? And during hard extended exercise, those amino acids are used by our muscles. So to help our muscles not to deteriorate as much during exercise and such, you can of course administer amino pep to put in those BCAAs. And it can be used for persons who are elderly. Persons who are 70 years and older can experience sarcopenia. And of course, leucine can help with that. Patients who are going through convalescence, excellent choice. Again, it contains the amino acids. Not just that, but it also contains vitamins like vitamin A, the B complex, including vitamin B12. It contains vitamin A, vitamin E, vitamin C, and vitamin D3, as well as it contains zinc and folic acid and calcium, which is quite relevant for your patients. So again, it covers under convalescence, right? To help to reduce and shorten the recovery period, as well as it can aid wonderfully in stress and fatigue and weakness, as well as in pediatrics. It's excellent for kids 18 months and above, for children. Kids who may need help with their, mental health. I mean, their, for kids who are at school need help with their mental, vitality, for kids who are into sports, as well as kids who don't eat properly, or kids who only want popcorn, chicken, or and such tasty. Not fighting against those brands, but they aren't adding much nutrients to a child's diet. So in those cases, you can also supplement your children or your patients with AminoPep to incorporate those missing nutrients and vitamins. So that's again, it's our AminoPep. It looks like that over the counter. It's caramel flavored, 200 mils in our bottle. It looks lovely with gold and green. So before, the amino acids are in there, the vitamin A, vitamin D3, E, B1, B2, niacinamide, 6, folic acid, calcium, B12, ascorbic acid, and zinc. I know we're in COVID times, right? So persons who have or who are COVID prone, which we all are COVID prone, hence again, take your vaccines. Vitamin D3 again helps to boost the body's immune response, as well as zinc, of course, with the immunity, as well as vitamin C. So it's quite rounded for persons who not only who are in sports medicine or who, let's say, have injury, but persons who just want to try and have a healthy lifestyle to incorporate those nutrients that are missing maybe in their meals. So persons who maybe who have cancer, who have HIV, who work long hours, who are critical thinkers, persons who help with their skin and nails, and so much more. Dosage for adults, we say 10 mils once or twice daily. For kids, 5 mils once or twice daily. And it's sweet to the taste. It contains sorbitol, so it won't affect anybody's sugar levels at all. As well as if the patient is diabetic and doesn't like the sweet taste, that same dose of 10 mils into some water and drink it. It's quite fine for that patient. And just to compare other vitamins on the market versus our AminoPep, comparing it, we're having B complex and multivitamins, yes. Others do, yes, they do as well. Amino acids, we do. Many of them don't. We contain zinc, yes, we do. Others don't. Sorbitol base, yes. Some others, no. And value for money, yes, we have value for money. And to show you as well, to compare for you, to show that in our AminoPep, 200 mils, not bashing any brand, chicken brand, showing a difference in price and content and value. So you can see that in our amino pep 200 mils, which other brands in the market, 200 mils, 30 tablets, and so forth, per bottle of 200 mils is $1,500 per bottle over the counter to your patients. Other brands in the market, and so forth. And you can see again the content of our amino pep, a whole lot of ingredients that can add value to all ages from 18 months and onwards. And again, to show you, your patients, your children, all can take it. It contains D3, vitamin C, zinc, and it can be paired along with the capsule to help persons who have sports injuries to help them to recover faster. Thanks for your time, AGPJ. As well as a point to note is that it is quite safe. Its ingredients aren't in contradiction with the JADCO restrictions or rules. It's quite safe for persons who are in sports as well. Thanks again.
Thank you very much, Ashley, for your presentation. And it is good to know that the ingredients in amino pep are also, we can use it quite without having any fear that it will go against regulations for our athletes. So we can,
yes, thank you.
Move into the presentation by Dr. Jones. So as said before, Dr. Jones would be known by many people as in his capacity as an orthopedic surgeon. And recently, he has received some additional recognition with interviews on the radio regarding return to sports with COVID, as well as being awarded the Certificate of Merit from the 2020 RJR Gleaner Sportsman and Woman of the Year ceremony. But just to tell you a bit more about him, Dr. Jones himself was an athlete. He spent his early years of school at Knox and Monroe colleges, where he performed he was not only academically, he not only excelled academically, but also in athletic events. He is a graduate of the University of the West Indies, where he earned his Bachelor of Medicine and Surgery degree, his MBBS, as well as his Doctor of Medicine in Orthopedics. He is also certified in advanced trauma and life support and advanced cardiac and life support. He is a member of various professional organizations, the Jamaica Orthopedic Association, Caribbean Orthopedic Association, and the American Association of Orthopedic Surgeons. He is the chairman of the Therapeutic Use Exemption Committee of the Jamaica Anti-Doping Commission, JADCO, since 2014, and the president of the Jamaica Association of Sports Medicine since 2017. He is also a member of the Jamaica Track and Field Coaches Association. He works at the Mandeville Regional Hospital and lectures at the University of the West Indies in the medical faculty. Dr. Jones has never lost his interest in sports, and his personal experiences has been used as an advantage to understand the needs of athletes. Through his assistance, he provides a sports medicine clinic where he works at Mandeville Regional Hospital for athletes. Today, in his capacity as the chairman of the Therapeutic Use Exemption Committee and a member of the Jamaica Association of Sports Medicine, he will speak to us on the classification of banned substances, timeline of drugs, to avoid when treating athletes for minor medical conditions in private practice. Please welcome Dr. Quinn Jones.
All right, thank you very much, Joan, for that that introduction. During the introduction, my internet went, so I lost the last part. So I'm sharing my screen now. Is this share screen is paused later?
We're seeing it. You just need to go into your full screen. Yeah, we just need full screen presentation now.
Okay.
I'll go to slideshow at the top.
1 second.
Slideshow at the top there.
Yeah.
Beside animation.
Usually just open it from down here. 1 sec. Okay.
Play from the beginning.
Play from start.
Yeah. There you go.
Right, so you guys seen this?
Yes, we are.
All right, great. All right, guys. I'd like to thank the Associate and General Practitioner of Jamaica for inviting me back to speak after many years. This Dr. Gordon didn't recognize that I presented maybe over 10 years ago down here in Mandeville at the Bloomfield Great House when my colleague and friend, Dr. Paul Kidd, was the president. I'd like to thank you again for giving me the opportunity to share some information with this wide group and essential part of the provision of medical services to patients in general and to our athletes. All right, so let's get into the topic. The topic sent me was this classification of banned substances, timeline, and drugs to avoid when treating the athletes for minor medical conditions in private practice. So to summarize that, what that boils down is adhering to the WADA rules and regulations. That's what that boils down to. So I'll hope to go through that during the course of this presentation. I have no disclosures. Well, only to say I was a lot younger when this picture was taken, and Joan already mentioned that I am the therapeutic use exemption chairman for JADCO. So a lot of this talk shall come from that perspective. So just a brief introduction. So during this presentation, it's a long presentation. If anybody has any questions, any issues in between, and they put them up and they want to stop me to ask me something, I will address it then to kind of break up the monotony of the presentation. The whole idea is that I will be presenting cases that are come in the news, so there are no secrets to anybody, and the issues that came up with them, what happened, and then how to avoid any one of us present to avoid those issues. So a brief introduction, you remember this from 2013, it was actually in the BBC.
One second, Dr. Jones. So you would welcome questions during your presentation?
Sure. While I go along to the because there'll be a lot of information and a lot of intricate things, a lot of drugs, a lot of things. So if during the presentation needs to be a point of clarity, just you're Sam, right? Sam,
yeah. So guys, just go ahead and raise your hand if you'd like to ask a question, and we'll try to have Dr. Jones do it at that point. Please don't raise your hand to say hi. Raise your hand because you have a question.
All right, good. All right, so back in 2013, I remember this German hue was banned by FIFA, right? So not just banned by FIFA for being banned for 9 months and pretty much ended his football career for being given dexamethasone by the team doctor. This is the doctor that was appointed to the football team by the medical officers, the medical person in charge of the Jamaica Football Federation. The doctor himself was also banned. I've excluded the name to avoid any, just in case, so, but all this is in the newspapers. The doctor himself was banned for 4 years, suspended from participating in being involved in any athlete for 4 years for administering that drug to German hue. And there's been a case in court about this. And out of this, the JFF Medical Committee head, this is a headline taken short after that, thought that the ban was extreme, and he had this comment to make. He said that in this case, the medical official just made an error, but that he did, that was correct, in not filling out a TUE form, which allows more leeway, and as we go through it, you recognize that that is not correct. So he did make an error, but he wouldn't have gotten a TUE for this for reasons we will explain later on. So questions, these questions appeared in a pre-test in multiple choice form. So by the end of this, you should be able to answer them fully. When is the WADA prohibited list published? So when it's produced? When does it take effect? All these things you need to know or be aware of. And is it a list of 3 different drugs or method categories on the prohibited list, as opposed to knowing every drug? If you know the categories, you can help you to identify drugs that might not necessarily appear on the list, but can give you an idea as to what substances and methods might be prohibited. When do you require therapeutic exemption for an athlete? And in an emergency situation, this is also very important, and we'll mention that, do you go ahead and administer prohibited medications to an athlete? And that emergency meaning you're saving a life. And this will become more important later on in the presentation. And what is therapeutic exemption and who is eligible for it? So all those questions appear in your thing. You won't pick up any licks if you didn't get them right during the thing, but hopefully by the end of this presentation, you will be able to be comfortable with and answer these questions. So the objectives here are hopefully to enlighten everybody who is logged on and at this presentation, and then anybody who may see it subsequently when it is posted on the various websites, to enlighten such individuals on the whole premise of the code. It's the code that is put forward by WADA, which pretty much governs the use of substances, drug, fair play, and all those things. Better understanding of the prohibited list and some basic code violations, and then things to consider when treating athletes with medical illnesses requiring prohibited substances or methods. Remember, it's not just drugs, but methods. And then how to apply for a TOE, which you should be familiar with. Now the code. The code is a fundamental and universal document that is put forward by WADA, which pretty much governs doping in sport. Sorry. Now the purpose of the code is going to a lot of kind of health kind of responses here. It's to protect athletes' fundamental right to participate in doping-free sport and thus promote health, fairness, and equality for athletes worldwide. It's to ensure harmonized, coordinated, and effective anti-doping programs at the international and national level with regard to 1, detection of substances, 2, deterrence, deterring people from using prohibited substances, and then to prevent prevention of doping in sport. And the fundamental rationale of the code is the spirit, is to promote the spirit of sport, is the celebration of the human spirit, body, and mind, and is reflected in values we find in and through sports, including ethics, fair play, and honesty, health, to make sure everybody stays healthy, and that they're not doing anything that's going to interfere or deter their health, their state of health, excellence in performance, character and education, to make sure athletes are educated about everything, fair play, etc. Fun and enjoyment, teamwork, dedication and commitment to the sport and to fellow athletes, whether they are teammates or on other teams, and that's the whole idea of fair play. It's the whole purpose for the code, again, to respect for the rules and laws that govern each sport in particular, respect for self and other participants, and then all these other health types is courage, community, and solidarity, and stuff like that. Now, athlete support personnel, and while I talk about this because this includes us, and that is why the doctor who had administered the prohibited substance to Jermaine Hugh was banned, because athletes and support personnel fall under the whole guise of the code, and we are subject to the same rules and regulations that go towards athletes actually go towards medical and parapersonnel personnel. All right, so yeah, coaches, trainers, managers, agents, team staff, officials, us, medical and paramedical personnel, parents are included as well, relatives, anybody who is involved in an athlete's life falls under the codes and is sanctioned by any active action that it might take that might compromise the athlete or compromise their ability to adhere with the code. So it's any other person working with, treating or assisting an athlete participating in or preparing for sports competition. And these are some of the roles, our roles and responsibilities: to be knowledgeable of and comply with all anti-doping policies, which what we hope we'll be able to do at the end of the session, or at least partly, rules adopted pursuant to the code and which are applicable to them or the athlete whom they support. To cooperate with the athlete testing program, which means providing relevant information to JADCO and other stakeholders who are involved in ensuring that athletes and athlete personnel adhere to the code. To use his or her influence on athlete values and behaviors to foster anti-doping attitudes. And this, when we go into the different substances and other aspects of it, you will understand where that comes from. You'll understand more. And if you know of a situation where an athlete is using banned substance or whatever, it is our duty to disclose to our national body, which in our case would be JADCO, or to the International Federation, of any decision by a non-signatory finding that he or she committed an anti-doping rule violation within the previous 10 years. If you know of something that took place within the last 10 years with an athlete and as relevant association is not aware of, it is our responsibility to let them know, because if it comes out that such a violation was committed and we knew about it, and worse, we were the ones that prescribed the medication, we are also open to sanctions if necessary. And of course, to cooperate with the anti-doping organization investigating anti-doping rule violations. More stuff on the code, in terms of the rules and responsibilities of athlete and support personnel. These are the athlete support personnel, shall not use or possess any prohibited substance or prohibited method without valid justification. So we shouldn't be walking around with anabolic steroids or oral prednisone or IV hydrocortisone without valid justification for having it on our person, especially when we're traveling with teams. You know, so that's something that we need to be aware of. All right, another story plucked from the news to back that up. So in 2011, if you remember this, Simone Forbes, who was one of our best dual sport athletes, one of the few females, I'll always say, along with Barbara Agatha Buckley-Jones, to captain 2 national teams. Simone captained both volleyball and netball in her day and was a pretty good athlete, went to the World Championships and everything like that. She was banned for 3 months for returning an adverse analytical finding for clomiphene. And I know what clomiphene is. The doctor who was involved was her treating obstetrician. She was trying to get pregnant, and he prescribed clomiphene, which is rightfully so. Right? The issue though was that she did not get a therapeutic use exemption for this. The doctor didn't present information relevant to JADCO to get an exemption for this medication, which would have been justified based on the legitimacy of the drug. So initially, the doctor who was involved professed ignorance, which is what usually happens. And he was ignorant of the fact that one, Forbes was a national athlete, and I'd have to say a national treasure, given the fact that she did captain 2 national teams. He was unaware that clomiphene was on WADA's prohibited list of substances, as in his mind, it's such a weak drug. He didn't know about the performance-enhancing properties of it, and as a result, he had no clue. So hopefully at the end of this won't be my name or your name there. Dr. K. Gwynne-Jones professed ignorance to the fact that person was an athlete, etc., etc., etc. So this is to avoid these headlines appear with our names in the future. All right, so all of this, in terms of the list, is premised on the list, right? That's the list of the prohibited substances, which we shall go through in some detail. Now, WADA took over the response to the list from the IOC, the National Olympic Committee, in 2004. Now, remember, the list identifies substances and methods prohibited in and out of sport competition and in particular sports. One of your questions. It is prepared at least 3 months before it's published, i.e. usually by October 1st each year, not later than that, but by October 1st each year it's prepared and made available to all relevant personnel. You can go and see the list by October 1st each year and know what is coming out on the list and what
think we have lost Dr. Jones. System seems to have frozen.
Yeah, it seems he's having internet problems. You guys can hear us, but not Dr. Jones. All right. Let's give him another minute or so to see if his internet comes back.
Take effect in
back.
January 31st.
We lost you for a little, Dr. Jones.
Yeah, I realize that. So the manual internet is acting up, and when it's ready, it rears its ugly head. So let me, and it's decided to do that now.
Go back to the list.
All right, back up. You see me, Joan?
Yes. All's good.
Great. All right. So hopefully it will behave itself, but it has a tendency to be very emotional, especially in this time of lockdown. All right. So it's available in both electronic and hard copies. Like I said, electronic copy comes in a PDF, and you can download it from the WADA website and have it on your laptop, and it's easy to search. You just click find, you can plug in the name of the drug, and it will find if it's there and tell you what it's about if it is there. I say it's both hard copy. There's a hard copy that's available, and that is available from WADA directly. Like I say, it's published in English and French. If there are any queries with this, as opposed to a drug, etc., the English version prevails. So some French person saying that this appeared on the French version and they gave it based on this, but the English version doesn't have it. The English version prevails. And if you have something on the soft copy that you can download and it's not on the hard copy, what is on the hard copy is what is prevailed. And that's a copy of the first page or the front sheet of this year's prohibited list. And why is it important that you know all of these things? 2016, plucked straight from the headlines. Maria Sharapova, former tennis #1, won Wimbledon when she was like 17 years old. Of Russian descent, she was taking meldonium from 2006. Now, meldonium was a drug that in Russia that they gave to the troops who were fighting in the hills and so forth, and helps improve cardiac function and overall metabolism. So it does performance enhance, but it wasn't on the ban list, not 2006. She was unaware that it became a banned substance in 2016. Between 2011 and 2015, it was being evaluated by WADA, and during 2015, it was on the monitoring program. Now, what happens on the monitoring program is that for all the samples that are taken at the major meets, WADA processes the samples and analyzes the substances in there. And what they found was that during competition, levels of meldonium were significantly higher than they were outside of competition. So they realized that athletes were using it to get an advantage. So from September in 2015, it was made known that meldonium would become prohibited as of January 1st, 2016. It was sent out to all the various stakeholders from the 2016 before October 1st, and all relevant persons were notified. Ms. Sharapova didn't get the information, wasn't aware of it, and her stakeholders weren't aware of it. So when she tested positive for meldonium at the Australian Open, she was subsequently banned for a period of time. Hence the importance of knowing, checking out the list from October 1st, the year before when it is available, and knowing what's going to happen on October 1st. So if you have an athlete on something, it's always wise to just check to see if it is going to be on the list for the following year. Especially if it was on the monitoring program from the years before, it's important that you know that it's a possibility that it could become banned the following year. Now the layout of the list, all right? Another one of your questions. This is the basic layout of the list. 3 broad categories. These are broken up into substances that are prohibited at all times, meaning that regardless of when you are found to be taking this substance, it is considered to be an adverse analytical finding and can incur you some time away from the sport. And there are substances that are prohibited in competition, and these are all competitions. So there are substances that you can be taking them outside of a competition, then you're fine. But however, once a competition starts, if you're tested positive during that period of time, then that you will be charged with a code violation. Now, a competition starts usually from they tell you from 11:50 night, the night before the official start of the competition, and it ends by 11:59 of the end of the competition. Whatever the dates are published for the competition, so the competition is scheduled to be from September 1st to September the 4th, from the night before, September 1st, so right at the stroke of midnight. Anything you take from on the 4th is considered to be in competition, whether you are competing or not. If you are part of that competition, that is the time period of which you are considered to be in competition. And then there are substances that are prohibited in certain sports, and we'll go into all of these things during the course of the presentation. All right, so substances prohibited at all times. I'll run through them and then I'll go through them a little more in detail. So these are non-approved substances. We'll mention what those are. Anabolic agents, peptide hormones, such as growth factors related to growth factor related substances, and substances that mimic these substances. Beta-2 agonists, yes, beta-2 agonists such as what you use to treat your asthma, and we'll go to that in more detail. Hormones and metabolic modulators, of which mendonium was one of those. Diuretics and masking agents, not so much that they're performance enhancing, but if you take these drugs, they help to hide drugs that are performance enhancing. So although diuretics and masking agents are not performance enhancing, once you are found with them, you're going to get the maximum ban because you could be hiding drugs that carry very severe penalties. All right, so other things that are prohibited at all times: manipulation of blood and blood components. So these are blood transfusions, or if you're taking blood out of your body and giving yourself back. And then also chemical and physical manipulation of samples. So if an individual is found to interfere with a urine sample or a blood sample after it's taken, that's all prohibited at all times. And then intravenous infusions, and this is extremely important. It's more than 50 mils in less than 6 hours. The 2021 has 100 mils in less than 12 hours, so 6 of one, half dozen of the other. And that is important because there have been instances locally, some of you online might have been involved, know about situations where you've had doctors, team doctors for local high school football teams, track and field teams, giving intravenous transfusions of vitamins, of greater than 50 mils before that game and so forth, and all those things are prohibited. I know there are drugs and methods that are prohibited in competitions, such as stimulants, that you classically find after your over-counter medication, narcotics, cannabinoids, such as our good old marijuana, and then glucocorticoids. These are things that are inhibited in competition. And then there are drugs that are prohibited in particular sports, such as alcohol and beta-2 blockers. These sports, when we go into that, if a substance or a method is not defined in the list, please verify with your anti-doping agency whether or not it is banned. Because you can recognize that the list can't be exhausted based on the fact that drugs and methods are being produced on a regular basis. And so if something is not on the list, it doesn't mean that it's not necessarily prohibited. It would be wise if you're unsure to check with your local anti-doping agency or anti-doping officer to clarify whether that substance is banned. Now, the monitoring program, as briefly mentioned, that the monitoring program consists of non-prohibited substances. So you'll see on the list a lot of drugs that are being monitored. These substances are not banned. What is being monitored is are the levels that they appear in the urine in athletes. And like I say, in the time a monitoring program shows a drug that the presence in the urine is significantly higher than it would be normally, it tends to incur a red flag. And then these substances are prohibited when urine concentrations are above a certain level. And like I said, it's a red flag, and it can result in that drug being banned in the future. So pay attention to drugs on the monitoring program, because in the following year, like meldonium for Sharapova, it can become banned. So follow that. All right.
Hold
So
on a second, Doc. Hold on a second. I think, I think Dr. Jean Williams Johnson has a question to ask.
There are a few questions coming through.
What's that?
No. He's actually caretaking a property. That is majority.
One second.
Sorry, all right.
This is Jamaica. You don't have to do this. It's all spotty.
All right.
All right. There was something in the chat about if athletes, if before competitive season, if the use of marijuana, if they can smoke weed in the off season, if that is okay. And
is that okay? I mean, as far as a prohibited thing is, yeah. So marijuana has actually been removed from the list, and is actually and if you smoke it in the off season, that's fine. Fine in quotes, you know. So I mean that has been based on local laws and so forth. But as far as water is concerned, it's fine if you just make sure that you declare it. If you get tested out of competition, just say, well, you were smoking some weed last night, some ganja with some friends, I think and so forth. So when it shows up, it won't become an issue, right? But if you're smoking outside the competition, that's fine. You won't get charged for a doping violation if you get found with cannabinoids in your system outside of competition.
And two other questions from Mr. Keith Campbell would like to know if Viagra is on the list, and what is the problem with the use of prednisone? Or is there a problem?
Well, all right, so we'll go into the prednisone a little bit more, we'll go on further, but Viagra is not on the list. Yes, it's performance enhancing, but it's not currently on the list. The increased blood flow that it does, it hasn't been found to be performance enhancing, but it's not on the list, or neither are any of the erectile dysfunctional drugs. Yeah, there's none of them are currently on the list. Prednisone, we'll talk about that later on, but it has more to do with it interfering with the test for other steroids. It's not performance enhancing, and we'll talk about that later. You will need a TWE for it, but we'll talk about that later on when we get into the glucocorticoids. Any other questions? I can clarify right now.
No, you can continue.
All right. So non-approved substances, these are prohibited at all times. Now the S0 class, now what this refers to are any pharmacological substances with no current approval by any governmental regulatory health authority for human or therapeutic use. So this includes a lot of stuff that is being developed. So all drugs that are under trial, drugs that are used in veterinary medicine, you know, talk about the horse tonic, that, you know, the song about the horse tonic and stuff like that thing. So, so any substance that is not approved for human consumption is prohibited. So stuff that is used in veterinary medicine and not approved for human consumption, all of these substances are prohibited. So chicken pill, all those kind of things are not approved for use. So do not advise people to take these or give them to take to improve their performance. Now your anabolic agents, now this includes your anabolic steroids, whether they are exogenous coming from outside or endogenous if you're given exogenously. So testosterone is an endogenous anabolic steroid, but if you take it orally, take it from outside, it becomes exogenously administered and it is prohibited. And other anabolic agents, such as the beta-2 agonist clenbuterol, which is a beta-2 agonist which has anabolic properties and helps to improve the lean body masses of individuals and, more importantly, in animals. Substances like these are used to improve lean muscle masses in animals, in particular in cattle. And as a result, people can become contaminated with it from eating beef, in particular, meats that have been animals that have been fed or treated with these such agents. And most recently in the press, you'd have recognized that there was a young athlete who got off from a doping violation because he returned an anabolic agent, which is commonly found in meats from countries which use these agents to improve the lean muscle, the lean mass of cattle in particular. And there was a World Cup, a junior World Cup, it might be over 10 years ago. It was in Mexico. I know Mexico is one of those countries that use such agents where entire teams were found to have tested positive for I don't remember if it was clenbuterol, but for an anabolic agent, which was derived to be from contaminated beef that was served to the teams. And so there were no violations that were handed down to any other footballers who are involved in that competition. It was a junior World Cup or youth World Cup a couple of years ago. You can Google it and find out. So yes, so the reason why the kid got off was because the levels in his system were consistent with the levels that would have been found in contaminated meat. If the levels were higher than what you would expect to find in contaminated meat, then you'd have to explain yourself for that. Now, peptide hormones, growth factors, and related substances. So a lot of these things are probably self-explanatory, and you could probably think on why these substances would be prohibited. The things like erythropoietin, anything that stimulates erythropoietin receptors to cause an increase in your blood count, and anything that would non-EPO receptor agonists, anything that would enhance the performance of erythropoietin is prohibited. Any condition that you might do, any method that you might use to produce or induce hypoxia, such as inhalation of inert gases, such as argon, helium, etc., to reduce your oxygen inhalation quantity and hence stimulate increased erythropoietin production, and as a result, red cell production. All those things are prohibited. Training at altitude is not, though. So if you train at altitude, which is a natural way of increasing all of those things, that is not prohibited. But if you artificially do it by inducing a hypoxic state, that is prohibited. All right, so gonadotropins, that you figure anything that interferes with hypothalamic pituitary gonadal axis, all those substances are prohibited, and you recognize that clomiphene would fall under one of the under that class of drugs. Corticotropins, anything that stimulates these hormones or these growth factors, all those things are prohibited. Growth factors, growth hormone, no surprise there. Now, your beta-2 agonist, now this has gone through the ringer where it was initially prohibited at all times. If you do remember from, I think it was 1996 World Champions, 1996 Olympics, Linford Christie was provisionally caught with an adverse analytical finding for salbutamol, and then came out he was asthmatic and so forth, so he had a legal right to use it, and then he was actually exonerated subsequently to that. But since that, all beta-2 agonists are prohibited at all times, except, and this exception is important because you will all prescribe these for your athletes. Your athletes will inhale salbutamol, provided that you do not exceed the doses that's there, that's 800 micrograms within a 12-hour period. Inhale formoterol, which is a long-acting beta-2 agonist, provided that you don't exceed 54 micrograms for 64 over 24 hours, and inhale salmeterol. These are not prohibited, so you do not need therapeutic use exemption to prescribe standard inhaled beta-2 agonist for your athletes. There are some that are prohibited, which we'll go into, but these are not. So if by chance your salbutamol level, your inhaled salbutamol level ends up being higher than what you would expect for normal normal inhaler level, then
Dr. Jones, are you there? I think we're having some more Mandeville internet issues.
Yes, I think he's having internet issues.
No problem. In the meantime, while he's gone, based on his presentation thus far, there were a few questions that were in the pre-test, might be in the post-test. You can go ahead and let us Let me know your answers to this question while we work on getting Dr. Jones back.
All right, I'm back.
All right, Dr. Jones is back, and as we see on the screen, one of his questions was about the date that WADA prohibited list usually published. And Doc, I think you'll be proud that
most people got it correct.
Right?
Yeah. So people always think that January 1st, when it becomes effective, is when it is, but it's not. It's published well in advance, and it makes sense if you stop and think about it. All right, so I'm going back to my shared screen. Share. There you go. All right. All right. So right. So if you have to, as it has to be nebulized, you'll recognize that it's highly possible that they will end up with levels that are higher above the 1,000 nanogram per mil level of salbutamol in the urine. And as a result of that, they would require relevant documentation to explain why, i.e. emergency room notes, doctors' notes as to what happened, how the clinical presentation, when they came in, they were responding to whatever, and you might have to, you'd have to probably submit information for giving them intravenous hydrocortisone or oral prednisolone or whatever it is that you'd have to give at that time as well. Now, hormone modulators, aromatase inhibitors, so anything that interferes or blocks estrogen. So if you have an athlete who is coming back from breast cancer and is on one of these medications, as we do have one of our Olympians who Olympian medalists and world championship gold medalists who had breast cancer, had surgery and is back, and I think she was on tamoxifen or one of the estrogen receptor modulators. You need her to get therapeutic exemption to use such drugs and document it accordingly. So any other anti-estrogenic compound, not limited to drugs like clomiphene, which interferes with the axis to improve, to block estrogen stimulation of the ovaries. Hormone and metabolic modulators, agents modifying myostatic function, that's contractility. We talk about metabolic modulators, insulins and insulin, anything that mimics insulin. All of these are anabolic agents. Meldonium, which we mentioned before, or anything like that, which are performance enhancing, are drugs, are prohibited. Oh, come on. All right, diuretics and masking agents, anything that expands the plasma and makes you increase your urine output, such as intravenous glycerol and intravenous administration of albumin, anything that will allow you to excrete metabolites and so forth at an increased rate, are prohibited. In terms of prohibited methods, manipulation of blood and blood components. So what is happening back in the day, in the 70s, blood doping was a big thing where athletes, especially distance runners, would take their own blood and then they would go train at altitude for an extended period of time, come back and they would administer back their own blood after that, you know, and that would improve their oxygen carrying capacity and so forth. So any manipulation of blood or its components is prohibited. I say if intravenous infusion of any fluid at all of greater than 100 mils per 12 hours, which is on this list, or what was on the list in the past, was 50 mils within a half an hour. All of these things are prohibited. And there, of course, there's an exception, and that's if you have to receive in the course of a hospital admission for a surgical procedure or clinical investigation. So, you know, like some antibiotics come, you have to dilute them up to a certain amount, or if you had a diabetic perhaps who was hypoglycemic, I had to give them 50 mils or more of 50% dextrose in water, you would have to explain that, right? So blood transfusion, all these things are prohibited methods. And no surprising there, gene doping, and that includes gene editing. If you're excluding a gene that might inhibit performance, or silencing a gene that may prohibit performance, or inhibit some other gene expression, then all of these things are prohibited, and that's no surprise there. All right, substances and methods that are prohibited in competition. So, like mentioned before, these are something that if you take within the period of competition, it's prohibited. Now, people might ask, if you take the drug up to the night before, that if you take the drug up to the night before, then would not show up in the system? And the answer to that is yes. The thing though is that the level of the drug in your urine is what counts. So if you're taking something prohibited in competition, it would go for ganja, marijuana, or cannabinoids, more exactly, before competition, up to the day before, and then you test positive in competition. It's the level of the cannabinoid in your urine that will determine whether you were taking it in competition or not. And that is what becomes important. And that's the whole thing, like with meldonium, when it became prohibited on January 1st, when the in 2016, the 2016 list had levels 1 month after, 3 months after, expected levels based on the excretion rate of meldonium. So yes, people tested positive for meldonium up to 6 months after, it became prohibited. However, the levels in their blood was consistent with somebody who was on the medication up to December 31st and had been gradually excreting it over those ensuing months. But however, if the level was high, which was what happened with Sharapova, the level in her urine was significantly higher than what you'd expect for somebody who had stopped taking it on December 31st. So yes, substances prohibited in competition will show up in your urine during competition. However, the level that it is in the urine is what becomes critical. Also, these include stimulants, those that are specified and non-specified. And that is important because there are a lot of stimulants that appear in supplements and performance enhancers, which natural performance enhancers, which are not specified, which will be flagged and prohibited if you test positive for such drug. So those stimulants that are non-specified, and those are very clearly specified, but not limited to. And this includes that methylhexanamine, which is what Nestor Carter tested positive for 10 years after the fact, which we had issues with, but we'll get to that another time. Ephedrine, methylephedrine, oxylofrine, which is what Asafa and Sharon tested positive for taking a supplement that was given to them or recommended to them by their agent. Pseudoephedrine. Sorry, and these, as you recognize, are substances that appear commonly in over-the-counter medications that you use for nasal decongestion to treat seasonal allergies and the flu. All right, narcotic agents, fentanyl, morphine, oxycodone, and pethidine. Again, not so much that they're performance enhancing, but they can interfere with the analysis of samples, hence why they are prohibited. Glucocorticosteroids, all right? Now, this is important for, this goes to the question that was asked earlier. These are prohibited when administered by the oral, intravenous, or intramuscular or rectal route. So oral, parenteral, or rectal. You know, once you give these drugs via those means, they are prohibited. Hence why if you have an asthmatic who needs to take oral prednisone for their for their asthma, they would need to get a therapeutic use exemption. And again, like I said, it's not because so that is performance enhancing, but they do interfere with the analysis of specimens for more prohibited substances like anabolic agents, etc. Hence why they are prohibited. And that answers the question for prednisone earlier. So you would need, but the inhaled glucocorticosteroids are not prohibited. So your Becotide inhalers and so forth, they are not prohibited. Cannabinoids, I said, prohibited in competition. So if by chance they relax the night before competition, you need to have a light smoke by listening to Revolution from Bob Marley's album, then sure. But I said, the levels are significantly high, questions will be asked. Now, substances prohibited in particular sports. Now, these are prohibited in particular sports, but in some sports, they are prohibited in and out of competition. And those are archery. In archery, beta-2 blockers are prohibited in and out of competition. But for other sports such as racing, motor racing, billiards, darts, golf, shooting, beta-2 blockers are prohibited in and out of competition. But skiing, these drugs are not, underwater sports, they are not prohibited they're only prohibited in competition. However, for archery and Olympic shooting there, as you see there, beta-2 blockers are prohibited in and out of competition. So you would need to get these athletes therapeutic use exemption from the get-go if they're on it for some kind of cardiac issue. They need to get, but for those that would only be taking them in competition, you would need to justify why that was and get them a therapeutic use exemption for them to take it in competition. And just some of the beta-2 blockers that you're all familiar with there. Now, therapeutic use, so that's pretty much covers the list. And like I said, I tried to go through
Take a few questions, Doctor.
Sure.
There's a question here. Testosterone is sometimes used for delayed puberty. The correct procedure would be to apply. Would the correct procedure be to apply for a TUE?
Most definitely. And we will get into the details of that now when we finish this aspect of it, which will answer some of your other questions. You will recognize when you definitely need to apply for TUE. But if you need to give testosterone, I would say for anything that is in keeping with best practices, i.e. recommended by all the relevant professional bodies, then sure, you need to get a therapeutic exemption for it. But if it is just based on a way more fancy of yourself, like giving dexamethasone for treating chronic fatigue syndrome, then you're going to run into problems, which is what happened with Jermaine Hugh.
Would that also apply to EPO for chronic kidney disease?
Definitely. Anything, so that's justified there again. So I ironically, I had a sister who had chronic renal failure, so I had EPO stacked in my refrigerator at home. Right? So if there was a raid at my facility at any point in time, I had ample justification for why it is that I had EPO in my fridge. In fact, I had some in there well after she had passed and things. But yes, you definitely need that for EPO for somebody on renal failure, diabetics on insulin, etc. So we'll get into that more. I think all those, anything related to that therapeutic exemption for legitimate medical condition, we'll get into that right now. Any other question not directly related to that, Joan?
Yeah. Do we use clenbuterol in Jamaica?
To treat our cattle? No. What for my research, it's been used mainly in Latin and South America. Central and South America is where they use it. It's not used in the US or a lot of the UK large markets. I don't think in Australia either, but where I found that these anabolic agents are being used to enhance the lean muscle mass of cattle. It's been in Latin and Latin America or South and Central America. And that's just where that World Cup was, where you had that large return of adverse analytical finding several footballers from multiple teams. But yeah, but we don't use it in Jamaica.
There's another question about anabolic steroids with respect to Semenya, Caster Semenya, and competing as a female due to her testosterone levels versus allowing males who identify as women, so we're looking at transgender, to compete as females with possible steroid treatment with the obvious advantage due to their male bodies.
Right. All right, so that's a topic for another day, but I'll briefly run into it since it's something that Joel, as you know, had spoken about extensively at different points in time. So the whole issue with Semenya and other individuals like her, and why it is that it is difficult for the IAAF, no World Athletics, to allow individuals like her to compete with women is that they are. And this is what, if you read the whole thing and you go into the court of arbitration, I'd gone through this before, I had a different presentation, and what has transpired and why the court of arbitration has upheld IAAF's banning of Semenyas competing with women is that for all genetically male athletes, these are XY athletes, trying to compete as females, they have a clear advantage of their ability to use testosterone physiologically. So we know testosterone exists in both males and females, but only individuals who have the Y chromosome are not only, but individuals who have the Y chromosome are better able to use testosterone most efficiently. And as a result of that, have a clear advantage over XX individuals who are using testosterone or who have testosterone. And as a result of that, in order to maintain a level playing field and to ensure for fairness within the sport, that is why World Athletics, so the World Athletics recognizes that, yes, it is biased, right? However, in order to maintain a level playing field for XX females, XY females have to maintain their testosterone at a certain level to prevent them from having an unfair advantage in certain sports. And that is why when after the whole Semenya thing, I know some local people were emailing things, and I know the World Association of General Practitioners had some letter they wanted people to sign and blah, 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 and stuff like that thing. But I don't think they were fully aware of the big picture as to why it was why World Athletics currently has to maintain their stance on that, and why Semenya and her personnel have lost every time they have gone back to CAS to try and get it overruled. CAS recognize that they do have an unfair advantage because they have a Y chromosome. They have a Y chromosome, so they are able to utilize testosterone like men can. An XX female, regardless of how much testosterone you give her, she will not achieve sporting levels of men.
All right, Doc, thanks so much.
We have about 5 minutes left.
I was about to say about 3 minutes left at this point.
All right. So therapeutic, that was off topic. So therapeutic use exemption. All right. So this is a required permission document provided by a local or international governing body for an athlete with a documented medical condition, must be documented, to use a prohibited substance or method. Now, how to apply? Now, there must be clear documentation of the medical evidence that the condition exists. So you must have all the relevant lab tests, etc., which say that the person is diabetic by giving it a tour, postprandial or whatever. That the illness occurred if it's somebody that had to be treated in an emergency situation and got a variety of drugs, like an allergic reaction I had with that athlete back in 1986. I had to give him IV hydrocortisone or nebulizer and everything like that. You have to have clear documentation that the illness occurred and he got a TUE after the fact. Medications required and the doses used, that they are in keeping with what are best practices. The treatment medication and protocol are in keeping with best practices. We say there no. The other thing is that there is no other safe or reasonable, non-prohibited alternative or substance that exists to treat the conditions. Like we had an athlete years ago who said he was taking furosemide for asthma. And yes, there are documented journal articles in some Italian journals using furosemide to treat certain asthmatic conditions. However, there are clearly a lot of other more non-prohibited medications for use of treatment of asthma, which would not have warranted or justified his use of a diuretic to treat his asthma. Right? So after you get all that information is submitted to the whereabouts and therapeutic use exemplar officer Jadco. Oh, that's an old reference. So they're no longer on South Odeon Avenue. They have their own building off of Balmoral Avenue. I changed all of the things in the slide. I didn't change that. So they're now on Balmoral Avenue. I can let that your associates know about at a later point in time. If you Google them though, their new address, I think all the phone numbers still apply. Right? After you get such information, it's submitted to a panel of medical specialists in their different fields, not unlike the group of gentlemen you see standing there. And these individuals consist of both men and women. Look over the evidence and make sure that it is in keeping with, again, diagnosis of the illness, that the medication prescribed is in keeping what is best practices. And then this goes into another case plucked from the headlines. My individual back in 2017, one of our athletes was given clomiphene and mesterolone for supposedly infertility in a young male under the age of 30. He said it was a life-threatening condition, but as you recognize, it's only life-threatening for the children that you're trying to have. It's not life-threatening to you. So there was no justification for this. The individual again claimed ignorance was the primary defense. He never heard of a therapeutic exemption or JADCO or anything like that. And in this case, again, this would not be something that would be justified for a life-threatening condition because it is not. All right, he never visited JADCO's website or anywhere to find out about it. All right, there's a few other kids from the news. There was Shelly Ann got banned for taking a narcotic back in 2010. She was given it just before a race. I think her coach got frustrated because she was having a bad toothache before a 100-meter final at one of the Diamond League races. It wasn't Diamond League then. Yeah, it was Diamond League then. And he gave her a narcotic agent to reduce her pain. She never performed well, and she got suspended for like 3 months. A short suspension. A brief thing on supplements, because a lot of you will be approached as such. Right now, supplement by definition is anything given outside a regular diet to supplement to enhance a body's dietary insufficiencies. It must be very clear on what IWF World Athletic has to say on this, because people keep saying that the IWF says do not give supplements, and that is not entirely true. It's just like people saying that the Bible says money is the root of all evil, and it does not say that. It says money, the love of it is the root of all evil, not money itself. So the same thing with IWF. It's not that they say that they don't take supplements. They do say that in certain situations where an individual has a documented insufficiency or deficiency, of which increased diet is not an option, or the diet will not be enough to offset that deficiency, short-term use of a supplement is recommended. And that is always in keeping with their medical personnel and so forth. However, this does not compensate for poor food choices. The issue with supplements that they do have is that supplement market is unregulated. So anybody can put a supplement out there and tell you that it is this, that, and the other. There are a multitude of companies providing a variety of products. You don't know about the safety of the drug, the purity of the drug, and the labeling can be an issue. So much so that Food and Additives and Contaminants journals show that 7% of herb supplements contain ingredients not listed on the label. And that's the issue. Not so much what is on the label, but what is not on the label. And then 1 in 4 supplements may lead to a positive IWF test and do not contain the dosing ingredients that are on the label. And that includes banned drugs and so forth. All right, and that it can include steroids, etc. This came out of a court case from 2010 where a supplement that was being used there had a banned amphetamine in there, which is a banned stimulant, and individuals were tested positive and received suspensions for taking supplements that had a stimulant in there. And that was it. So in summary, medical personnel, which are us, we play a pivotal role in helping our athletes adhere to the code. In certain situations, we can be charged or sanctioned just like an athlete. Therapeutic exemption is required for all athletes required to take a prohibited substance, to use a prohibited method for a documented medical condition. Over-the-counter medications have bad substances in them, so
I think Doc's internet chipped out again, unfortunately. However, we're at that time now, Dr. Hatchery, where I think we have actually finished. Yeah. So I think we'll go to the agenda and continue to our next presentation.
All right. We would like to thank Dr.
Read the ingredients label
Jones
carefully to make the medications. If you're unsure,
sorry, Dr. Jones,
that's it.
We had, yes, your internet went out again, and we have to move to the next presenter. I'm sure that we thank you very much. It was very comprehensive. I know it must have been very difficult because the water code is of prohibited substances is long, and you did a very good job in trying to bring it to us in a very condensed way, and we appreciate it. And I'm sure many persons have been enlightened and will be more take more time to inquire of their either young or masters sportsmen and women, if you know, if they are in competition, because that's where it really matters as to whether a TUE is required or not. So we're moving on to the next presenter. So we have a sponsor's presentation coming up next, and I believe
MedImpex Jamaica.
From MedImpex Jamaica. So we'll have Mr. Paul Dennis, who is going to be presenting to us next. Thank you, Mr. Dennis. Welcome.
Thank you very much. Are you hearing me?
Yes, we're hearing you, Paul.
We're hearing you.
Okay, I'm about to share my screen. Good afternoon, everyone. My name is, as you heard, I'm Paul Dennis from MedImpex Jamaica Limited, where our motto is first-class products for healthy living. And in keeping with the topic of sports medicine, I'd like to present some products that are related. So we'll talk about some pain management and some other products that I think you'll find quite interesting. Here we go. So our first product is, let me get my, yes, is Midocar. This is our skeletal muscle relaxant, and it's available as 150 milligram tablets. It's given 3 times a day, and it's indicated for a lot of indications that once there is skeletal muscle spasm. So for instance, we have here muscle spasm due to locomotor disease, shoulder pain, back pain, rheumatic disorders. We have here muscle spasm due to peripheral vascular disorders, so leg cramps at night, diabetic angiopathy. And for the physiotherapists in the house, muscle spasm due to painful physiotherapy. So Midocar will help to relax those muscles. And also the muscle spasms due to neurological disorders. As I mentioned, it's given 150 milligram 3 times daily to a maximum of 300 milligrams 3 times daily. As of this time, the 150 milligram tablet is not recommended for children. Another product that we have is it's an NSAID with a little bit of COX-2 selectivity, and it's called Meloflam. We like to say it will get your mobility back with Meloflam, all right? It's available as a 15 milligram tablet. It is scored, and in some cases, we start off with 7.5 milligram, especially in cases of exacerbations of osteoarthritis. And in rheumatoid arthritis, we start out with 15 milligrams, also ankylosing spondylitis, where after a while, we reduce it to 7.5 milligrams. Help to protect the stomach that way, all right? And as you can see, there are some cases where you might see a patient with joint pains. A point to note, it's not really for acute pains, it's more for chronic pains, all right? Our over-the-counter products, we have here Radiant B, long-standing product, been around for a while. We have it available as ibuprofen gel. We have the Radiant B spray. We have the muscle lotion and the muscle rub. And it gives fast relief from muscular pain due to stiffness, sprains, arthritis, tennis elbow. Now, our location has changed. As I see here, the old location, we're now on at 21 Balmoral Avenue. So you can be contacted there. Now, as was mentioned earlier by Dr. Hudson and Dr. and Dr. Mansing, compression is important in the treatment of injuries like this. So either you're using the police or the Rice method, the C is always there, compression. So we have with us some products called Protect. They are orthopedic supports and they're recommended for everyday use, sport use, or just work. If you need to go to work and you have a joint pain, it's flexible enough for you to wear it all day, all right? The mission of Protect is to provide quality, great quality and affordable products for pharmacists and sports professionals. So not only for sports professionals, but for anybody who have these issues that needs support. Support and compression is important because, as you know, support offers support for weakened muscles and joints to provide some therapeutic warmth. And the compression rate is from gentle to firm for these orthopedic products that we're talking about, Protect, all right? The Protect line of support comes as elasticated and neoprene. So let's start off with the elasticated products because we want you to be aware of what we have. So we have the knee support, ankle support, elbow, wrist support, and hand support. Now, it's important to know, and the physiotherapists in the building will tell you that they like to stretch these things to see if they are really flexible. Most of all the products, except the wrist, offers 4-way stretch. The wrist support offers a 2-way stretch. Important to note, they're all breathable. So it will handle sweat a little different, allow the skin to not get too hot and all of that. And it can be used for all day wear. All right, so let's start off looking at the knee support. The knee support, as you can see, it's the direction that it should be put on. As you can see, some persons tend to turn it around, but as you can see, the front part here should be at the front, as you can see. Also, I would like to point out that it can be used for arthritis, prevention of further injury, minor sprains and strains, and it's available as from small to extra large, and it gives a support of 2. We have here the elasticated ankle support, also prevents prevention of further injury and also helps with arthritis and so forth. And it offers, we offer it from small to extra large as well. We have the elasticated elbow. We have the elasticated wrist support. This uses a hook and loop fitting, and it's breathable. And as I mentioned, this offers 2-way stretch, not a 4-way stretch as the others. And we also have the elasticated hand for repetitive strain injury, prevention of further injury as well. And it's also lightweight and it has an anatomical design. And it's a 4-way stretch. Now for the neoprene. The neoprene, they offer heat retention and more compression. So you'll use this for more moderate pain. So we have available the knee support. We have the open knee. This is for the patella. We have the open heel, the elbow, and the hand support, the wrist support as well. All right, just showing you what they look like. This is the open knee as well. Open ankle. Sorry, I'm going too fast. Yes. This is the open heel, very comfortable to wear, and it offers a little heat. So the whole body heat it tends to trap it and help to offer more blood flow to the area. We also have the elbow, the hand. This uses a hook and loop, and it's a universal fit. Most of my orthopedic surgeons tell me that they prefer the universal fit. So, they don't have to worry about measuring and all of that. And we also have this soft foam neck collar. It's unisex, and we have it available as small, medium, and large. It's also breathable, so it can be worn a little longer without getting too sweaty. This is one of our newer ones, the pouch arm sling. It's available for junior and for adults, and it is a universal fit. So for support level of 2. And for a specialist Protect support, we have our neoprene knee stabilizer. This one it has a hook and loop. It also has an open patella, and it has 4 integrated stabilizers. So we use this for people who need extra support to reinforce the knee, prevention of further injury. And what I must point out, this now has a higher level of support. It's now at a 5. There's a 5 rating. All right, so you're gonna get more support, easier to stabilize those knees, the knee, especially patella. Also, it's available from small to extra large. All right, so we cover all the sizes. Here we have the neoprene thumb brace with splints. It has 2 splints. It's a universal fit, and it has a hook and loop, and it can be reversed. It can be put on the right hand or the left hand. All right, so it's support for weakened or injured thumb. All right, and a point to note, the splints are removable. Here we have one of our top products. It's a breathable wrist splint. It is used for your carpal tunnel syndrome or weakened and post-cast wrist and repetitive strain injury. It has, as I mentioned, 2 splints. It has a hook and loop. Also, it is reversible, whether you're left or your right hand, it doesn't matter. And it offers a support rating of 5, right? This is another favorite with my doctors who stock these products because they don't have to worry about the size as well, because it's a universal fit. Also, this is fairly new, or elasticated back support. And this one has 8 stays. The stays are right here at the back. These longitudinal things that you see in the back here, they are the stays. This one has 8 stays. And it has a dual belt system, and it's an adjustable hook and loop. However, this one is available in 3 sizes: medium, large, and extra large. It offers a firmness level of 5, and it's used to support weakened or injured back or abdominal sprains or minor back pain. All right. Now, just to give you an idea of the cost, you might think that these products are expensive. They are really not. These are the prices from Medimpex, where you can see that most of the products are less than $1,000. But for the specialized one like the back, it's about $2,200, and the neoprene knee stabilizer is $1,950. These are the prices from Medimpex. Of course, pharmacies might have a markup of 40% or more, but want you to know that these products can also be purchased directly from Medimpex at 21 Balmoral Avenue. All right. So I want to thank you all for listening. Thank you for your time, and enjoy the rest of your program. Thank you very much.
Thank you very much, Mr. Dennis. We appreciate it. I think physiotherapy, that the mitochondria is taken by the patients before they attend physiotherapy, not because physiotherapy is going to cause additional problems. But
no. That is just to ensure that your job is a little easier. The physiotherapy
definitely
easier when the doctor prescribes it.
Help us with our job. All right, and we're moving on to our next sponsor presentation. This is from Abbott Nutritionals, and its presenter is going to be Mr. Paul Russell. Welcome, Paul.
Okay, thank you. Start broadcast. All right, can you hear me?
Yeah, Paul, we're hearing you. We can see your screen.
Okay. All right, good afternoon, ladies and gentlemen. My name is Paul Russell, as was mentioned, and I'm from Abbott Nutrition. I'd like to thank the members of AGPJ for the opportunity to present to you this afternoon. Today, I'm just going to be reminding on some of Abbott's products. So let's start with Juven. Juven is a therapeutic nutrition powder, which when mixed with water or juice and taken orally, helps to support wound healing in as little as 2 weeks. Regular diets may not provide enough of the critical nutrients necessary for healing, and Juven supports wound healing from the inside out. Whether the wounds are from pressure ulcers, diabetic foot ulcers, surgical incisions, burns, radiotherapy-induced injuries, and vascular wounds, Juven, with its powerful ingredients, arginine, glutamine, HMB, collagen protein, and micronutrients, is able to help enhance patients' outcomes when taken twice per day. Now, coming soon, moving on to Ensure. Coming soon, Ensure will have a plant-based protein nutrition shake. It's made from the fava bean and peas, and the product is soy-free, dairy-free, and has no artificial sweeteners, and is non-GMO. Ensure plant-based shake has 20 grams of protein, 5 grams of fiber, and it's only 180 calories. So soon, possibly by as early as ending of May or June, the Ensure portfolio will be Ensure Original, Ensure Plus, Ensure Enlive, Ensure High Protein, Ensure Max Protein, and Ensure Plant-Based Shake. So whether the needs are for nutritional support, weight gain, or maintaining muscle, all that's required is to recommend the right Ensure to help patients reach their nutritional goals. Similarly, for your diabetic patients, Glucerna, the portfolio includes Glucerna Shake, which is 180 calories and 10 grams of protein, Glucerna Hunger Smart, which is 180 calories and 15 grams of protein, and Glucerna Snack Shake, which is 140 calories and 7 grams of protein. And for the children, ages up to 13, from 1 up to 13, to help support growth and development, there's Pediasure Grow and Gain, which is 240 calories and 7 grams of protein. We have Pediasure Grow and Gain with fiber, which is 240 calories and 7 grams of protein as well. We have Pediasure Sidekicks, which is 180 calories and 10 grams of protein. And soon to come is Pediasure Grow and Gain Organic with 240 calories and 7 grams of protein. Now, I've included my business card as well, which clearly shows my cell number and my email address. Bear in mind that my email address has my name spelled Russell with 1 L at abbott.com. I'm located at Caramed, so feel free to make contact with me. Looking forward to interacting with you. And I thank you very much.
Thank you very much, Mr. Russell. That was short to the point. It's great to see that Abbott products are going across all ages, from our young to our old, and especially the fact that you're coming up with a plant-based product soon, which I know the vegetarians or the persons of vegans will probably appreciate quite a lot, because it's the amount of protein that it's going to be made available in that product. So once again, thank you very much for your presentation.
Okay, thanks for having me.
So we're now moving on to our next presentation, which is going to be done by physiotherapist Justine Edwards. It gives me pleasure to introduce Justine, my colleague. She's relatively a young therapist in the field, but one who has demonstrated a lot of interest and commitment to her profession, and especially working towards the management of sports-related injuries. She's a graduate of the UWI School of Physical Therapy, having graduated in 2014 with her bachelor's in physical therapy. And then she continued her education at the University of Nottingham in the United Kingdom, where she graduated in 2017 with her Master's of Science degree in Sports and Exercise Medicine. While studying in the United Kingdom, she successfully completed internships with the National Center for Sports and Exercise Medicine, Birmingham Royal Ballet, and the Royal Derby Hospital, and at the Royal Derby Hospital. Locally, she has gained experience through engagements with the national cricket and netball teams, in addition to covering international tennis federation qualifying tournaments. She combines her experience and training in exercise and science to achieve excellent results in restoring her patients to good health and returning them back to work or sport in the shortest possible time. Justine has been a member of the Jamaica Association of Sports Medicines since around 2015, and I am the chairman of the education committee, and I have pulled her in under my umbrella in the planning and execution of various activities. She has assisted with the 2019 biennial pre-conference workshop on exercise prescription and fitness testing, and has been a contributor to our newsletter on injury prevention and management. This afternoon, Justine will be presenting on rehabilitating the injured athlete. Please welcome Justine Edwards.
Hi, good afternoon, everyone, and thank you so much for that introduction, Dr. Ratri. So before I start, I just wanted to say thank you to the presenters before me, Dr. Hudson, Dr. Mansing, Dr. Jones, for just making my presentation a little bit easier. So maybe we can actually finish before time. So let me just get into the presentation itself. And everyone is seeing the screen, right?
Yes, everything is coming in clearly. Just need you to go to full, there you go. Perfect.
Let's begin. So just to make this a bit easier and cohesive, I had put it in the form of a case. So just to give an introduction of what we're working with. So a 22-year-old male, CB, he is a business host, footballer, and he also plays recreationally as well in his community. So he presented to the practice with a 5 out of 10 discomfort whenever he was ascending or descending stairs. History of present complaints: a few weeks ago when playing football, sorry about that. When playing football with his friends, the patient had decided to juggle before kicking the ball, and on doing so, he felt a pain in the medial aspect of his right knee. He had decided to seek medical attention and was referred to an orthopedic consultant and subsequently referred for physiotherapy management. His past medical history, as Dr. Mansing had mentioned as well, if injuries go untreated, they're more likely to reoccur. So a year ago, the patient had stated that he was running backwards and stopped suddenly and turned in a football game when he had felt a sharp pain followed by a loud sound and subsequently fell to the ground. He had attempted playing, but was unable to do so as he felt as if the knee was giving way. So it's also important to note as well, is that he went home and iced. He visited his general practitioner and was given NSAIDs and given 3 days rest, which had helped. And he had went back to work, had no pain, any issues at all. But the only thing is he didn't do physiotherapy, and possibly, I guess, he didn't think that he needed it at the time. And he had stopped playing football altogether until that incident a few weeks ago. So on observation, he had an altalgic gait. There was moderate effusion around the knee, and as well as muscle atrophy, which were noted around the quads. On examination, there was a 5-degree extension lag. And when asked about this, he had said that he was afraid of straightening the knee because whenever he did so, it would feel a little bit weird or as if it would shift. And there was also pain along the medial joint line during palpation. He had a good muscle strength throughout right hip and knee, except for his hip rotators and knee extensors. Functional test done was he had a slight discomfort during squats, and he also had some discomfort going up and down stairs. And the special test done was the anterior jaw and valgus test, which Dr. Mansingh had touched on earlier as well. So in summary for the assessment, agreeing with what the consultant had sent to us by referral, he had also done, which is a consultant, orthopedic consultant, he also did the Latchman's test and the anterior jaw test, which would confirm that the patient did have a grade 1 ACL sprain and a medial collateral ligament injury as well. So because it was a grade 1 sprain, he would have been able to return to sports without any need for surgical intervention. So just running briefly, the function of the anterior cruciate ligament. So the anterior cruciate ligament provides approximately 85% of total restraining forces of anterior translation. So in other words, it prevents the tibia from sliding in front of the femur, as well as it provides rotational stability for the knee. And of course, as physios, clinicians, you would need to know how to identify the difference from a sprain and from a tear. So a grade 1 sprain, these are micro tears within the ligament. When it is slightly stretched, the person is still able to fully weight bear and can carry out function for the joint is still stable. A grade 2 sprain, the ligament is moderately stretched and partially torn, and ambulating has now become a bit difficult. They're still able to carry out their function, but the joint now becomes loose and you'll hear them describing it as such. A grade 3 sprain, the ligament is completely torn. The person is now unable to ambulate without having increased pain and would definitely need surgical intervention as the joint is now unstable. So I know that Dr. Mansingh had an image, as well, of what these grades would look like. So from coming to what A being normal, B being slightly stretched, where we can see where with C it's partially torn and D completely torn with rotational forces. So just running quickly as well through this, the anterior jaw test. So we would have just to let you guys know how we conduct these special tests. So the anterior jaw test is having the patient lie supine. The hips will be flexed at about 45 degrees and the knee at 90 degrees. So in this picture, you would see where the examiner is sitting on the person's foot. So this is just to stabilize the limb. And then one hand would be on or just below the tibial plateau or the joint line. So what is required of the examiner is just to pull the knee forward. And if there is, what we do is just to compare that translation. If it is more than the unaffected side, then we can suspect that there is an injury to the ACL. It's also good to note that from Katz and Fingeroth 2013, that this test, the anterior jaw test, it has a sensitivity rate of 22.2%, and a specificity rate of more than 95%. So this is a good test to use as well. And as Dr. Mansing, I guess you guys will hear me referring back to Dr. Mansing, as he had brushed on or covered some of these tests as well. So Dr. Mansing had mentioned for the Latchman test that you have a bit more of stabilization when you put the examiner's knee under the patient's knee. So the Latchman test, what you're looking for again is gapping of the knee with the knee slightly bent at 20 to 30 degrees. Again, the patient is lying supine. So what we're looking for is that pull or translation of the tibia away from the femur. And again, this test is very reliable, as the accuracy rate and sensitivity rate is 77.7%, and specificity rate, sorry, is more than 95%. So as physios, we always would have goals and aims of treatment for the patient. So according or based on what CB had presented to us with, the aim of treatment would have been to decrease the pain and swelling, improve his strength, improve and maintain function, and having gradually progressed to returning to sport. So questions were asked earlier, what was the difference with police and price? So traditionally, rice and price have been the most common use of first aid management to reduce pain and swelling. I won't go into it very long because again, it was already done. But the purpose of, or what it was done or understood, was that when you rest, you wouldn't want to trouble the joint or the muscle. And of course, ice will assist with inflammation. And with compression, you would have increased or a pressure gradients, which would then counteract with the swelling, and elevation would help to reduce that as well. Protection, as Dr. Mansing had also said, was the including assistive aids such as braces, crutches, or slings. And this is just to protect the joint or muscle from further injury. So again, rise, compression, and elevation. So with police, during the protection phase, we have optimal loading, and optimal loading is what replaces rest, as optimal loading will allow for the patient to be able to move. Gentle motion can now be carried out through this protection phase, but there is a but. We're not asking the person to wear the brace and do a 50-meter dash. What we're saying is that according to the clinician, based on their assessment, they'll be able to have a better judgment as to how much load that patient can take. So with optimal loading, you can also have healing, or it will assist in the stimulation of healing for the joints, the bones, and the muscles as well, which is why there is now a call for police, as this would also help with reducing and or preventing or slowing down the chance of losing the muscle bulk and preventing the muscles from becoming tight as well. So that's police. So we know with everything in life, you have do's and you have don'ts. So according to Bruckner and Kahn, we would tend to follow these rules as to what not to do in the first phases of the acute phase or time of injury. So within the first 72 hours, it was advised to avoid from heat, as this would increase bleeding at the injured site. So we would say not to use any hot baths, any hot showers, to go in a sauna, just to avoid this within the first 72 hours. Refrain from drinking alcohol, mask the severity of your pain, and then it can also cause you to re-injure yourself again. So, and R, not to run on the joint or moderate activity, which again can increase the chances of re-injuring. So this one is there because in Jamaica, when you do your assessment and you're talking to the person and them say, you know, I just feel a little pain, but we feel like we could have just run again and it would have worked itself out. So we are saying no, try not to do that, especially within the first 72 hours. And also, I know that somebody had asked a question during Dr. Mansing's presentation about deep massage. So we are saying within the first 24 hours to 48 hours that you do not, or you try to, as much as you can, avoid doing deep massage or vigorous soft tissue therapy, as this would increase further bleeding and can cause swelling around the injury sites as well. So getting into physiotherapy management when the patient is presented to us. So depending on the physiotherapy private practice, every practice will have different methods in treating in terms of modality, what is available to them. So you'll have not one physiotherapy practice that is the same. So with saying that, I had decided just to go through the most common modalities that would be seen in a physiotherapy practice so that you guys can have an understanding as well. It's also important to know that physiotherapy, we use different methods and to reduce this as well, reduce the pain. So it comes in the form of either manual therapy, which is the deep massage or cupping, electrotherapy, and exercise. So just to go through briefly, so TENS versus EMS. You might be familiar with the TENS, but just to go through as well, this is the transcutaneous electrical nerve stimulation. So it is a handheld device connected to adhesive wires or electrodes. It transmits low voltages of electrical signals to your body, which then stimulates the nerve endings to allow your body to create endorphins, your feel-good hormones, which would then block the pain signals via the pain gate theory. So TENS we know is used for pain relief. The EMS, it's electrical muscle stimulation machine. So it's also a handheld device, but it transmits stronger electrical impulses, and you would place these over targeted muscle groups to achieve muscle contraction for the purpose of building muscles. And moving on to the therapeutic ultrasound. The therapeutic ultrasound uses sound waves that penetrates the skin, which aids with swelling, inflammation, increasing local blood flow, and then relaxing muscles, as well as the breaking down of scar tissues. So I know our med rep had just briefly gone through the brace. So during our protection phase, we would generally advise the athletes to get a knee sleeve. So the brace would offer some support and it would assist with pain as well. So this example is the elastic flexible knee brace. So it allows for more movement and you're able to function with it. There are other types of knee braces, which was also discussed by the med rep. So the other one we would use, which has straps, we would use this more in the example of a knee brace. The straps for if the person has some bit of more instability. So we use this more for persons who needs moderate support. And lastly, for the other type of knee brace, we would call it a hinged brace. So this brace, it limits movement. You wouldn't want to get much movement out of it, but you would still use it to protect the joint. And we'd mostly see the hinge braces, after surgery. All right, and kinesio tape. So these are not just colorful tapes that you see on athletes, you can use them on your patients as well. So the kinesio tape, it decreases pain, improves circulation and assists with the lymphatic system, and it supports the muscles and joints as well. So moving on to the rehab part of or management, sorry. So when thinking about exercise, as physios, we would generally think of two categories, and those two categories of exercises are the open kinetic chain exercises and the closed kinetic chain exercises. So the open kinetic chain exercises, it ensures that the hands and feet are not in a fixed position, and we use this to improve strength and range of motion. The closed kinetic chain exercises, the distal aspects of the extremity, the end of the free end is in a fixed position or fixed to an object, and this exercise is more based towards preparing the person for functional activities. So which is better? So even though my patient didn't undergo surgery, but it was just good to understand what you're working with and what exercise regime would be better in order to get your patient back into play or sports. So Euchre et al. In 2014 in his study had assured that the closed kinetic chain exercises were more effective than open kinetic chain when regaining mobility and enabling a quicker return to daily and sporting activities. So now I have broken down the exercises that we would do on a weekly from week 1 leading up to returning to play. So in the first week, CB had a bit of an extension lag. So the knee extension exercise, you have the option of putting a ball or a towel underneath the knee, and the person is required to, the instruction is to press your knee down towards the table and to hold that contraction. And you ask them to hold it for at least 6 seconds at a time with maybe 3 sets of 8, for example. The other exercise is the straight leg raise. So the person can be in this position, or they are mostly seen in a supine lying position. So you'd ask the person to flex their foot or to tighten the instep and have them raise their leg up to the level of the calf. Again, you would ask them to do, in the beginning phase, 3 sets of 8. Sideline hip abduction, person lies on their side, required to lift the leg on top, apart from the one that is lying flat on the bed. And it's also important to look out for rotation of the hip. And again, you can ask them to do 3 sets of 8 reps. All right. Prone line hip extension, the person lies flat on the tummy. The instruction is to clear the thigh off of the bed and return to the start position as well. So here we had mentioned, well, I had mentioned earlier that there is a technique of manual therapy. So cupping has become very popular in physiotherapy as well. So I'm just going to show a brief clip as to how it's done. So the purpose of cupping, it's a good alternative for doing a deep massage, because to be honest, our hands do get tired. So the cups are a good alternative for getting the muscles to be loose and to break up scar tissues as well. We often refer to it as trigger points. All right, so let me find. So you have different types of cupping. So you have the vacuum cupping, which this person had, where you had hook it up to a machine and then the air would be sucked out of the cups and then it would grab onto your skin and essentially your muscle as well. So you'd also want to find out where those tight spots are, and you would place the cups accordingly along the injured side that you are working with. All right, so for example, this may have been where he spotted some knots or trigger points that he wanted to work with. And in this next part of the video, I really wanted you guys to see the variations of it. So we can leave these cups here for about 5 to 10 minutes to allow increase in blood flow over these areas. Or we can have the patient do what we call a heel slide. So we're having active movements, which would then promote the further loosening up, further loosening up of the muscle itself. So this part is to show you guys an example of that. So he will demonstrate a few heel slides. So you just ask the patient to do a few of them, maybe about a set of 10, and this will loosen up the quads as well. All right, moving on. So to week 4 to 6. So in this phase, we would want the person to begin regaining some joint stability and to also focus on cardio, maintaining some form of a bit of fitness, as well as looking at the person as a whole. So not just working the knee, which would what the open chain kinetic exercise would do, just focusing on the knee. And the beauty about closed kinetic chain, which examples of these exercises is that it allows you to work more than one muscle group as well as more than one muscle joint at a time. So these exercises, just to go through quickly before this one is a video, the Y balance. It is the Y balance exercise is derived from the star excursion exercise. So it's a 3-point plane where the person is required to reach in different directions, which would really engage the knee joint. So you'd want to promote or learning to have joint stability, as well as the proprioception, the awareness of the joints in space. And so I'm just going to go into the Y balance one. So just trying to remember where to. Oh, and important to know the Y balance. So not only is it good for joint stability, it also aids with strengthening the gluteus medius muscle, which is also a good hip stabilizer as well. So let me just go quickly to where that video starts. So if you look closely to his knee, it engages the leg that's not moving, required to stay in place and not shift all over the place. So this exercise would be good, as I said, for joint stability. All right. And then wall sits. So with wall sits, this is a full body workout as it engages the glutes, hamstrings, adductors, quads, and your core. It does everything. So as you can see in this picture, the person has their hips and knee flexed at a 90-degree angle with a ball in between the knees. So you would ask the person to just hold, for starters, just to hold it for 15 seconds, and gradually you can progress accordingly as well. So the reverse lunges, as physios, we would also plan our goals and also think about how did this injury occur. So for the reverse lunge, for CB, bringing it back to my patient who had been running backwards when the injury had happened. So not only would you want to regain the joint stability and to strengthen the surrounding muscles of the knee, but you also want to regain confidence in the patient to do or to carry out a function that in his mind would cause a re-injury to happen. Hopefully that made sense to everybody. All right, so playing for you guys. So this video actually explains the exercise itself. All right, so that video was pretty clear and straightforward. So I would just jump into the next exercise in this phase, which is the step-ups. So the step-ups, once again, purpose for it is for joint stability and to be able to control the knee in different directions as well. So you'd have variations. You can either step up or lateral steps, which is stepping to the side as well, where you would you step onto a box, and drive the knee, the opposite leg, forward as seen in this picture as well. So with the step ups, we use it also to strengthen, and so you can either, how step ups work, you could either change the amount of reps that you do at a time, which would be geared more to strength and joint stability, or you can do it based on time. So for example, for the first session, you could let the person do 30 seconds of 3 reps and increase that amount of duration for the person, which would then develop a cardio, or allow the person to develop cardio fitness as well as endurance as well. So moving to the task-specific activity. So during this phase or in this time, you would want activities to prepare the athlete to go back to what they're used to in their sports. So just going through 4 examples as well. And these are all videos. So the first video that you will be seeing is I should not forget that maintaining flexibility during this time is also important, because as Dr. Mansing had also mentioned, you can't just focus on strengthening the affected side, you'd also have to maintain the flexibility in the joint, because if the muscles that is surrounding for example, the knee joint is tight, then you can cause yourself or the patient re-injury as well. So flexibility is just as important as strengthening. And just going to show you some examples of some stretches that we would do for the muscles that surround the knee joint. All right, so first he will go through a hamstring stretch, the calf stretch, and one for the quad. And there are variations to it, but this is what the video had shown. All right, so those were the 3 stretches that we would use. Again, there are different variations to these stretches as well, but just wanted you guys to get an idea as to what those stretches would look like. So the next video that you are supposed to see is a jump box. So this is more for a plyometrics effort. So plyometrics, it just means you want a bursting motion as well. So burst and or power for the muscle group itself. So this is just a progression. All right, so not to exhaust you guys, I'm just going to show you the other examples as well. So this one is just jumping up and down in one place, and you can progress to a single leg. But the other video to show you guys, which will be more geared towards agility and how fast you can move in a given time, because footballers would need that as well. All right, so this is fast feet in place. So we know that you do this in drills, or sometimes you can see them going along a rope. And this is what the forward skip would look like. All right. And each of these exercises can be progressed as well. So lastly, the one that I had wanted to go through as well. So you can run, walk on a treadmill. So this method, again, helps to build up the endurance in the patient or athlete, and preparing them to go back into sports in what they're used to. So for example, for CB, being a 22-year-old footballer, you are required to do 45 minutes before you get a break during halftime. So your endurance levels would have to be up as well. So for this one, you could start, for starters, for example, is to start with a 5-minute run with a rest period of a 1-minute walk on the treadmill. So again, in wrapping up, for physios, we do take the persons through the acute phase, either using the modalities of TENS, EMS, ultrasound, advising them to use the knee brace, as well as the kinesia tape. And then we get into the exercises, which would then progress them into their return to play. The progression of these exercises, we can either increase the weights, increase the reps, increase the velocity of it, as well as increasing the duration. And then for the example of plyometrics, which you saw with the jump box, is to increase the height as well. Also to note, when the person is going back to sports and to play, it would be good to have a good communication level with the athlete as well as the coach to find out what their normal training routine is. And then you would also develop a program surrounding that to have the patient gradually return to sports. So these are my references, and thank you so much for your time and listening to this presentation. I do hope that it was of somewhat of beneficial to you as well.
Thank you very much, Justine. Certainly is an excellent presentation, and you did so in really good time. I think there was one question that I saw in the Q&A where someone was asking about light therapy, the use of light therapy. And I think they meant heat, using infrared Could you speak a little bit about the application or the use of infrared? You're muted.
Yeah.
Okay.
So for infrared therapy, I hope that's what they meant. For infrared therapy, we don't usually use it. Yes, it's good to increase blood flow, but we more use it in the practice of wound healing. So it would help in the process of that. But in terms of an athlete, we don't usually use or our patients in the private setting, we wouldn't usually use that method, but certainly for wound healing as well.
If I can help, the infrared, as we know, is a method of giving off heat. So where there is a need for increasing circulation, as Justine has said, or if you have a heat lamp and you set it at let us say about a 2-foot distance away from the part, you can, if it's a muscle, not necessarily a joint would be for increasing circulation. Muscle, you could use it to produce a certain amount of relaxation because it would give a comfortable warmth, but I don't know that it is very much in practice. It's being used in practice much these days. I don't know if there were any other questions. Samuel, were there any other questions?
Not seeing any at the moment. Just kudos to Justine for the presentation in the chat. I think with all those videos and the details of the explanation, persons were able to not just, get a theoretical, but a practical look as to what Justine was saying. So I think that's why we didn't have that many questions for her.
Okay.
Well, the one just popped up. Let me see here. This is from Dr. Hussein White. Chronic back pain is a common presentation to the health center. If x-rays are normal and no complaints of radiculopathy, forgive me, is it appropriate to just write chronic back pain on the referral?
Well, usually that is actually what we see. So I would say I guess when you are getting your history as well as the physician, you would know. But usually we would, if there's no radiculopathy or x-rays are normal, we would tend to see mechanical low back pain, because usually it can be due to positional issues, which is why the person is having that problem. So if based on the x-ray, my opinion might be different from other physios. It would be safe to say mechanical low back pain, or you could actually use the chronic back pain as well. But you would have to, I guess, not guess, but when we do our history taking, we then would decide based on the questions asked, what exactly had caused this issue to have happened in the first place. Hopefully that answered your question.
Okay, so I think that answered the question. We have one from Dr. Arna Brown Morgan, and then Dr. Donald Gordon will ask you a question live. From Dr. Brown Morgan, how long to persist with PT on average?
2 months.
Well, then no one patient is the same. So usually we would give, depending on the severity of the injury as well, and how, all right, let me break it down. So the severity of the injury, you will also have to consider the patient's compliance to attending physiotherapy, as well as keeping up with their home exercise program as well. So all of that would have to be taken into consideration, but usually if the patient is a compliant patient, it would be safe to say about 2 to 4 months without having any pain and returning to normal function as well. That's just on average.
Okay. Dr. Gordon, question from you?
Thank you, Justine, for an excellent presentation. Oftentimes, we see patients come in with ankle injuries and they say that they have been using ice on it. What is the proper advice to give them, a person who has just recently received an ankle injury that is swollen? What's the proper advice in terms of putting ice on it that we should give them? Because they do all sort of stuff. You know, the length of time or how many days that they should use the ice.
Oh, okay. So as stated in the presentations before, you could use price. So you could have for how long to use the ice as well. You could use compression and ice for as often as every 2 hours for a maximum of 20 minutes over the period of a day and 3 days.
Okay.
Okay, thank you.
You're welcome.
And I think our final question is a follow-up.
If I can just put a point here for Dr. Gordon, it is also important, Dr. Gordon, to go back to something that that Dr. Mansing had introduced about the Ottawa ankle injury assessment, because sometimes depending on how severe the ankle injury is, we'd want to determine if there's any additional damage, that it is not just a ligament, if there's anything that is broken. And if it's a really bad ankle injury, protection is important, but we also might need to offload the joint. So the person may need crutches or some sort of supportive device. So the icing, a compression and ice and all of that, I think is very important for the acute injury, but it might also be necessary to offload the joint. It's within those 24 to 72 hours that Justine is talking about.
Thank you, Dr. Rattray.
Yeah, thank you, Dr. Rattray. And final question, follow-up from Dr. Arna Brown-Morgan. How does a doctor assess that the PT is a viable treatment for their patient?
I'm not sure. Is it Dr. Hannah Morgan? If she could further explain what she means.
So it's Dr. Arna Brown-Morgan.
Arna Brown-Morgan, okay.
Yeah, man.
Apologies.
No, that's okay. No, that's okay. Let me see if she can type her question here. Matter of fact, let me see if I can let her ask you the question live. Let me just activate her microphone and she'll talk to you. Dr. Arna, go ahead and let them hear your voice.
Right, Justine, I was just wondering if, you know, as a doctor, if you're sending your patient for physical therapy over a period of time and you're seeing them back and and sometimes you're seeing good results. Because sometimes, you know, the little box comes and it says, what do you want done? And you check off at the physical therapist's own assessment they treat. And that's what I want to know, is that sometimes you keep doing it and you want to know if there's a limit. You know, at what point in time, sometimes you ask for reports from the physical therapy, but there's a point in time when you just stop. Okay. And when the doctor knows to stop, to say, okay, let me stop doing physical therapy with me and the physical therapist, let me now go on to refer to orthopedics.
Oh, so you're asking if it is that the patient is not improving, so you'd want to know if you are to send them to a specialist?
Yes, but I want to know when, you know, suppose I have a physical therapist and it's going on, and I have concerns, and I want to, within my assessment, to know if the patient is, if I should persist with physical therapy. Do I just leave it, or do I go to the orthopedic doctor and let them take over then? Because this is what I guess I'm seeing.
Oh, okay. Well, after a few sessions, usually you would have a follow-up every 6 weeks with the patient and the general practitioner as well. I would say if the person isn't improving over a period of 3 to 4 months, then yes, I would advise that you would refer them to their orthopedic consultant. Also, to bear in mind that it would be also good to, if it is that you have some concerns with the method of treatment and the level of improvement for your patients, is to contact the physiotherapist and to even call, exchange some words, and if there is some clarification that you would need to get in terms of the treatment methods or anything of the sort, you would be able to ask them in person versus based on that progress report as well.
Okay, nice.
All right, thank you very much. Back to you, Dr. Rattray. That's
again,
it for our questions.
Thank you very much, Justine. I think you were very clear and the questions were well answered. I'm sure that our general practitioners have a better understanding of what the physiotherapists can do and how to monitor or manage their patients and when to send them on, refer them on if as needed. I would now like to invite Dr. Aldith Buckland, who is a member of the executive of the Association of General Practitioners, to do the vote of thanks.
Thank you very much, Dr. Rattray. It is indeed a pleasure and an honor to move the vote of thanks on behalf of the Association of General Practitioners of Jamaica. I'd like to acknowledge and thank the following persons. The Planning Committee, made of Drs. Donald Gordon, Peter Swaby, Seni Ononuja, and Aldith Buckland. We deliberated over the topics and what it is that we wanted to learn doing a sports medicine conference. How would the topics be helpful to us? And that's what we honed in on, and then we asked the assistance of the presenters, who were just simply amazing, as we have seen today. So we thank them. Also to the AGPJ administrator, Dr. Lynn Thompson, for her diligent work in making everything so streamlined and smooth, to getting our CME credits, to contacting Sam, to contacting the presenters, and indeed, just communicating with all of us so that we could have a really wonderful conference. And to the Medical Council of Jamaica, who was able to give us 5 hours of CME credits. Mr. Samuel Heron of Oldgate Solutions, who's our technical operations engineer and host. He did a fantastic job. To Dr. Donald Gordon, who gave us the welcome, and to our fantastic speakers, who not only prepared and presented on the topics, and trust me, to present and prepare is no mean task. It takes quite a bit of effort. And I know that each one of them literally thought about what we needed, what from their pearls that they could share with us so that we would actually improve our impact and our skill set when we actually look after our patients. So that you notice that all of them, they thought about how we could all work together collaboratively, not just in silos, but actually that we can refer to orthopedics, that we can refer to physiotherapists, because each discipline actually brings to the patient something so important that, that is going to actually assist in their rehabilitation. Because trust me, as doctors, we don't know everything, but as a team, we can work together. And Dr. Arna Morgan really brought out that wonderful question, how important it was to work in the team. And physical therapist Justine Edwards also brought out, having this meaningful communication between the persons who actually take care of the patient, and having the patient as the center, because the patient needs to let us know if they have been actually doing the work, So this is very important. So I really congratulate the speakers, Drs. Rhonda Hudson, Dr. Mansing, Dr. Kevin Jones, and the physical therapist, Justine Edwards. They did all such an amazing job. To the moderators, Dr. Peter Swaby, and who also did the opening prayer, and Dr. Joan Rattray, amazing job. And the participants, you all made this all worthwhile, upgrading our knowledge, attitude, and practices in sports medicine for general practitioners. And then our sponsors. May I have the next slide, Sam? Our sponsors, who are, we want to acknowledge Sanders, Indus Life Sciences, Medimpex Jamaica Limited, and Abbott Nutritionals. We acknowledge you and we thank you for collaborating with us so that we could really put on such a tremendous conference. Together, we all make it worthwhile. So thank you all for your role in making this Association of General Practitioners of Jamaica Sports Medicine virtual conference a success. And on behalf of the AGPJ, I wish you to keep safe as you take care of yourself, your family, your patients, and your community. God bless you all.